ATAL Academy, India, for sponsoring this program. A superhuman who turns bunch of dangerous chemicals into life, saving drugs, and a reason behind the doctor's success is a pharmacist. Pharmacists often give the painkillers the credit that ought to be given to the passage of time. The belief that they would kill the pain or the water that accompanied them. I wish all the distinguished pharmacists a happy World Pharmacist Day. Pharmacy, always trusted for your health. Let me introduce our speaker for the session, Mr. Sai Ramji, to the gathering for our talk, Digital Health and Smart Healthcare, a boon or bane. Sir started his career at DRDO Lab, Ministry of Defense, where Sir worked as research scientist, software engineering for 10 years and as head management technology innovation services team revolutionized the e-governance concept across the lab. Sir is presently working as Director, Global Delivery Center, Head, Microfocus. Sir had experience as Director, Global Technology Services, Cargill Business Services, Vice President, Digital and Automation, Enterprises Division, Tech Mahindra, Practice Head, Software Engineering and TT, HP Enterprise, Senior Project Manager, Ampersand Software Applications Limited, Bangalore, India, Computer Scientist, Ministry of Defense, DRDO Bangalore, India. Sai Ramji has been leading a global delivery center with transformed service offerings for customers across 3 geolocations. Global business transformation leader working through solutions and delivery strategies of the digital and automation business. Directly supported top line business growth and operational efficiencies in a career spanning 2.5 plus decades with the top organizations. To his credit of professional accomplishments, I would quote some of them. Youngest advisory member at Karnataka State Government IT Technical Advisory Panel during 1999 to 2000. Conceptualized or implemented one of the first and largest ATM networks in India in 1999. M&A member Digital Compact HP Major Clean Room in 2002. Leader for Oracle Stream Integration representing HP services during EDS HP Major in 2005. Leader for Industrialized Delivery Services for Global Application Development Stream HPE 2014. Conceptualized C2A Innovation Framework at HP Enterprises 2014. Member Board of Studies at 3 engineering colleges since 2015. Profiling blogger on digital topics like RPA, AI, analytics, blockchain, cybersecurity, smart cities, etc. Invited speaker at various global technology forums, meets, events on digital transformations. I would now welcome Mr. Sai Ram Bolla Pragada, sir, to present as a distinguished lecture and his insights on digital health and digital health and smart healthcare, boon or bane. I request all the participants to be proactive and participate in the session. Thank you so much. Now I invite Sairam sir for further proceedings. Over to you, sir. Thank you so much.
Thank you, madam. Good morning, all, and wish everybody a happy World Pharmacist Day. Right. Thanks to the Can you hear me?
Yes, sir.
Okay.
May I
Um,
request the video mode, sir?
okay. Sorry, I didn't turn it on. Okay. So thanks to the AICTE, the ATAL program Academy, and my Andhra University for providing me with this opportunity to talk, discuss, present, and deliberate on this topic, digital health and smart healthcare, boon or bane. When we bring in the specific concept of IoT, which is the main focus of the entire proceedings here, it means essentially then we are talking of IOMT, right? Internet of Medical Things. I will toggle between IOMT and around with some topics related to digital healthcare, and both together will constitute the topic of smart healthcare, boon or bane today, right? So let us look at how smart healthcare is transforming the caregiving industry and perception of us as citizens towards expectation from this field as a community. Okay. Um, so digital healthcare is usage of technology for provisioning of, and please note my words very carefully when I'm talking about these parameters. Digital health is usage of technology for provisioning of holistic, value driven, augmented, inclusive, data enabled, safe, connected, trustworthy, and secure healthcare. So that's a pretty wide definition of what digital healthcare is about. Let me repeat once again. It's a usage of technology for provisioning of holistic, value driven, augmented, inclusive, data enabled, safe, connected, trustworthy, and secure healthcare, right? So when we bring in the IOMT, let me give two examples here, right? Asthma continues to be a major health concern, particularly affecting children uh, because they are more vulnerable to this leading chronic disease, right? If not properly managed, asthma can become so severe and it can lead to fatal deaths, right? Several treatments are available in the form of inhalers whose aim is to orally administer medicine to those affected, and many of them require manual care. And Respiro Smart Inhaler basically it brings in the facility for telling you how your oxygen levels are and how your lung is functioning, and alerts you to take the inhaled medicine at regular intervals under strict guidance. Now, the otherwise, mechanism of treating asthma requires frequent visits to medical centers, right? And to have all the proper tests done for proper analysis, because this is not something that can be treated over the counter. With the evolution of internet into the medical field, many innovations have come up with a goal of improving healthcare, and one such innovation is Amico's RespiroSmart inhaler for asthma management. The other one that we often are subjected to is how do we monitor our cardiac health, right? So DigiRad has come up with mobile cardiac telemetry. It's basically cardiac monitoring device. This means the device is used to monitor the patient's cardiac activity. This device is so small, we can call it as a portable device. Uh, it's used to track the user and also to record the patient's heartbeat, pulse rate as the patient runs, exercises, is resting or sleeping. And a lot of these features have already gotten inbuilt into the wearables, like the one that I'm wearing here, right? It keeps telling me what is my pulse, if I'm running on a treadmill, if I'm sleeping, what my stress levels are, and so on and so forth. This would be much useful for the doctors because remotely the doctors cannot continuously monitor. But if it is recorded at a specific, data pattern, the doctors can look at how the heart is functioning, right? And advise the patients as to whether they should go in for a change, altercations of medicines, reduce, increase, whatever it is. So if there's a pattern that indicate a future heart failure, for example, the doctor could take an advanced predictive, treatment and check up on to see how to treat that particular event before it occurs. So healthcare to millions of people through IOMT and digital healthcare solutions and their integration and connectivity between, the aggregations are driven primarily by entities which are medical technology companies, but we call them medtech, right? So we will keep this terminology medtech and refer to it. IoMT is rapidly transforming medtech's role and relationships within healthcare. More specifically, connectivity between sensors and devices is enabling healthcare organizations to streamline their clinical operations and workflow management, and hence improve patient care, even from remote locations, right? And provided, bold italics underline, provided medtech companies can continue to convince clinicians and patients of the value and benefits of connected medical devices, the pace and scale of healthcare transformation will be exponential. And we have seen a lot of that happen during the last 2 years when COVID has struck us. So let's look at what is digital health then, right? Are you able to see my screen? Ma'am, are you able
Sir,
to see the
Yes,
screen?
yes,
sir.
Okay,
sir.
okay, thank you. So this is what I was saying, holistic, value-driven, augmented, inclusive, data-enabled, safe, connected, human, and trustworthy. And we'll look into the deeper parts of it. Collaborative innovation and solution across all levels. This is the key to helping digital health assist the caregiving industry. Collaboration should happen across. The data should come in from the lab technicians, the clinicians, the caregivers, the people who are actually taking the vital parameters of the patients, the doctors who are prescribing medicines, the improvement in the pharmacy segment on better drugs, right? Improved drugs. The collaboration has to be at all levels. Then you can have a collaborated, crowdsourced medical health improvement plan that can be targeted at driving satisfaction levels up. Okay, patient centricity, personalization, and human. Very, very carefully crafted. These three means that every patient is different. Every patient reacts to a particular drug or a disease very differently. And hence, there is so much of need for us to do personalization and human touch, which is so very important. These are some of the things that cannot be done digitally, right? This is one of the loopholes of digital health that you cannot in person, right, give the assurance. I'm sure during the COVID period, a lot of you would have come across a video where some people, some of the nurses in Argentina would fill up a plastic or a surgical gloves with warm water and tie it to the wrist of the patients while they are battling with COVID, right? To give them a reassurance that somebody is with you. So we say the moment you put a hand on a patient's body, right, they feel that much more psychologically comfortable, right? So it has to be targeted at ensuring that care is given, right? We make our systems more patient centric. We personalize it to their needs and their body behaviors. Patient satisfaction and staff satisfaction. The satisfaction is just not limited to the patients alone. The patients who are taking it and the caregivers who are administering the care to these patients both must be equally satisfied with the enabling components of digital health, right? Simply saying digital health will improve things is not going to be alone sufficient to improve the healthcare segment. Affordability is a big factor, especially in countries which are not very rich, where half of their population is below the poverty line, right? Many of them cannot afford an Android phone or anything of that sort. So, affordable healthcare for the payer and the society is a very, very critical component. And hence, you will see the kind of competition between different organizations, different companies, which are trying to bring in more convenient mechanisms of patient care, right? Access to the optimal level of healthcare services. Um, the access to the healthcare services has never been so compelling than in the past 2 years. People have gone and tried to make themselves self-sufficient, right? A lot of them have bought BP monitoring machines, sugar monitoring equipments, oximeters, for example, right? Because everybody needs care, everybody is apprehensive, everybody is uh, um, uh, always facing a risk of you don't know what is going to impact. And such has been the unpredictability of the healthcare scenario that the patients often start panicking, even at the slightest fever that they get, right? So, hence, quality of healthcare delivery and the service matters most. The outcomes matter most. And you'll be surprised when I put up the CSAT slide in the next, CSAT component in the next slide, that in spite of doing all these transformations, all these changes, all this technology that is being brought in, where does the patient satisfaction and caregiver satisfaction stand today? Prevention through education, information, empowerment, alert system. So, in the past 2 years, probably we have exchanged so much of information on corona that probably we are now used to getting into the below the skin depth when somebody administers a medication, right? Most of us, irrespective whether we are from this field or medical field or not, and let me know. I mean, I would definitely love to hear some of you talk about it. The moment somebody prescribes a medicine, you immediately go to Google and start typing, what is this medication all about, right? What are the side effects? Can it be given to my mother or father, right? Can it be given to my kid? Would there be long-term consequences, right? Everybody has increased their awareness. Of course, some of them are half-baked knowledge, which could still be very dangerous, right? But there is no denial that the education, the awareness, the information, the empowerment of knowing what is being done to you has grown multifold times in the past 18 months, 24 months, right? How many of you agree with it, right? Anybody has any comments to make on that? And I'll touch that. The expectation of digital health is faster diagnosis, faster action plans based upon the data that the devices and the components are collecting about a particular patient to ensure that they get timely help to be able to treat their diseases. Okay, I'll pause here. And anybody wants to comment on any of these parameters, please feel free to do that. Anybody?
Yeah, am I audible, sir?
Yes.
Yes, sir.
So actually, for the past 4 days, what we have learnt with that backdrop, I'm having a comment that the major issue when we are making this healthcare features in the digital in the hands of the patient, one thing is even 1% of the chances of failure, it leads to the irreversible damage to the patient, or it may not be worth to take that particular access to the patient's hands. So if you are digitalizing it and making everything in the hands of the patients, open to all, So it will obviously create the curiosity. So what it can be done is in this particular era, we can make the digitalization collectively accessible to persons. What content will be given to patient, what content will be given to practitioners, what will be accessible by the pharmacist and editable by the pharmacist. That
Correct.
is actually a correct to handle this particular what you have given excellent adjectives added to the digital health. So I
Exactly.
think entire thing can be amalgamated as a divine healthcare. I think that word it will be making it. I feel that is my
So,
comment.
just to, if you can go on mute, I can hear myself otherwise. Okay. You're absolutely right. So digital health is not one single stop resolution, right? Healthcare still needs human intervention, which is what I said: patient centricity, personalization, human, right? And that's what comes out, that digital health can be assisting to better the healthcare, but the human intervention is inevitable. Okay. But when you look at people like us, right, who are into the technology industry, what does it mean to us, right? New regulation, digitization, data analytics, artificial intelligence, automation, and the development of value based healthcare. Let us remember, value based healthcare, right, represents some of the numerous challenges as well as opportunities facing the tech industry. And consequently, the med tech companies, starting from startups to corporates, are reinventing themselves to remain competitive and relevant in the market. It's just not I made some application, or I made some product and threw it in the market, it'll be grabbed. No, everybody is very cautious treading this path, right? There are responsibilities that come along when you want to provide solutions and products to this industry. New strategies are needed to harness data provided by digitally enabled products and make their business and operating models relevant and sustainable. It's just not, I made something today, it will run for the next 10 years. No, everybody is challenging whatever you put in the market. So you have a stiff competition, right? This particular strategies or set of strategies will help companies develop evidence of better health outcomes at reasonable cost to obtain price reimbursement and gain market access. There is so much of crowd there, right? You will not be able to put a feet if you are not having a compelling solution or product. So for some medtech companies, this means shifting from product based model to a value based system driven by software based services and solutions. Okay. So we will delve a little deeper in slide 12 when we come into that, on the key consideration to drive medtech companies, how they should, what are the factors they should consider, what are the challenges they are facing, why they should be so aligned to the caregivers, what they should bring together so that they all are able to successfully deliver to the expectations of stakeholders. Remember, the stakeholder is just not the patient for us as technology companies. The stakeholder is the clinician, the patient, the nurses, the lab technicians, the people who are monitoring the health even at homes. They are also our stakeholders, right? So let's look at the 5 categories of healthcare or medical care today, right? The first one is in hospital. 3 categories, which are heavy equipments driven, which needs to operate in a well-oiled infrastructure ecosystem, right, is what should be done in hospital. And we will come to what can be done in hospital, what need not be done in hospital, right? The second category is on body. I'm sure many of you are already wearing watches or wearables, which are basically measuring your number of steps, right, that you're pacing up and down, number of your pulse rate, your stress levels, everything, right? And then there are implants, which are like something like a Libera, a chip on your body, which continuously measures your glucose levels, right? The veracity and the accuracy may differ from equipment to equipment. But what I'm saying is, if a doctor were to tell you you are heavily diabetic and you need to monitor your fasting PP1, PP2, PP3 kind of sugar levels every day for 15 days, which means 15 into 4, 60 pricks for a day, that is just 2 weeks, right? You can see that people will have sore fingers at the end of the 15th day or even earlier, right? So equipments like Libera basically help you to continuously monitor your sugar levels. And of course, I'm not saying that that's the only. There are many chips, many implants. The earliest one that we can relate to was pacemaker, right? But for pacemaker to be monitored or maintained, you would have to visit the hospital for the doctor to take a scan to understand what is the condition of the pacemaker that has been inserted and so on and so forth. But we have come a long way from those days, right? Second one is in home, which most of you would have experienced in the past few months, whether it is oximeter, BP machines, glucose monitor machines, more affordable types of devices which can be used by normal people without having to understand a lot, right? And then the clinical components like electronic health record or electronic medical record, which could you can treat as non-IOMT area, but the doctors where they are monitoring patients who need continuous care for a trauma or a medical condition would maintain the electronic health record where the history of the patient and the reactions to the dosage of medicines being administered to him or her. That happens in clinic. Now the fifth one is community, right? Which I think is there in many Western countries, but we need to develop the same more amongst the people in India. And I think in the last COVID period, we would have felt bigger need for that when during wave two we were hurt so badly that we were scampering for oxygen cylinders, for hospital beds, and so on and so forth. Um, so just not relying on government-funded community health centers, I think there should be a wider coming together of public-private collaboration where people build satellite community centers where people can be given something very simple like even vaccination. So vaccination till probably 6 months back was not door-to-door activity. Now I'm hearing even in Visakhapatnam, people are basically reaching out to the elders who cannot make it to the community centers, who are immobile, who cannot move around, right? They are basically saying, okay, we will come and administer those vaccinations. So the community development, the community knowledge is also equally essential to keep ourselves healthy, right? So let us see what has changed in the past few years, right? And what is driving those changes into this medical healthcare, industry. 100% mobile penetration. So much of usage of mobile, right? It need not be Android, but the SMSs can also spread a lot of information and awareness. We have 100 million chronic disease patients, right? There is a 2x growth of population which is 65 plus years, right? In that bracket, close to more than a million shortage in terms of doctors and nurses around. The doctor or nurse to patient ratio is abysmally bizarre, right? 500 million receive healthcare access via the apps today, right? And still there is this is pre-COVID. I mean, COVID, I would treat it as a very specific, condition, which is abnormal from every aspect, whether it is medication, whether it's symptoms, whether it is variants, whether it is recovery, whether it is recovery, post-recovery treatment, or whatever it is. So 45% mortality rates are still prevalent, right? Fast transition to mobile apps, and 89% of a certain group of people recommended is, yes, you should go to health apps, not just medical health apps like wellness apps. Headspace is one of them, right? It helps you to do breathing exercises, it helps you to do meditation, it helps you to if you're not getting sleep due to stress or whatever it is, it makes you feel better and get to sleep. 6 out of 10 people feel better patient care management is through alerts and reminders. As these population start graduating into senior citizen category, they often forget the medication, the dosages, and what you have. And most of the parents being remote now, all living by themselves, this kind of alerts or reminders are so critical for them, right? It helps them to ensure that without forgetting, they are taking their medications in the required or prescribed dosages from the doctor, and that keeps them healthy. And to quite an extent, it has also helped them to better understand their own health and their own body. The top three healthcare issues that are getting addressed today in a proactive fashion from some of these remote healthcare is diabetes, the first one. The second one is preventive care. And the third one is medical adherence, right? So let's look at some of these things. Health information is the third most common search request on the internet, but everybody's searching for what health information, how to keep myself better, how to keep myself fit, so on and so forth. 77% of patients use online sources prior to scheduling an appointment in order to learn about symptoms, treatment options, blah, 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 right? 66% of the population is willing to use wearables today because, somehow everybody has to be self reliant. And hence, they are depending more and more on some of these digital components to make themselves manage, monitor their health, and improve the treatment of these conditions. And one of the things, and I will come to the market size and market values in the next slide, but look at it from 2014 to 2022, in 8 years, right? The mobile health market, which was at 11.47 billion in 2014, is predicted to reach 10 folds, almost 102.43 billion in 2022, which is not too far away, right? So that's the size, that's the scale expected, that's the kind of movement that's happening from one segment of the medical care to the other category. Okay. So let's look at some of the real market trends. And this is all research data. All that I'm sharing is all researched data, right? The market for wearables will reach 46.6 billion by 2025. That's how many feel that this is going to be true. And if Corona has made any difference, what I can say is this number of 2025 would could be treated as something which is um, 2023. You can read it, right? A 2-year gap, you can always bring it in. IOMT, which we are talking in pieces today, right, will be a 6.2 trillion market by 2025. 2x more access to mobile apps. People are rushing to have medical health care being provided to them at their fingertips, at their convenience, right? And not travel for 2 hours and wait in long queues to get your token called and then go to the doctor. So everybody is wanting instantaneously, right? Mobile health apps, as I said, 40,000 mobile apps are already in the market. You go to your Play stores, you can find so many mobile apps which are all towards healthcare and wellness. $11 billion still by 2025 is the prediction, right? Artificial intelligence assisted healthcare market is slated to grow to 6.6 billion by 2026, right? And with all that, right, like I said, only 25% of the health takers and health givers are satisfied. You see, after doing so much, right, still the satisfaction levels is pretty low. 25% is not a great number by any mechanisms, right? Telehealth will still further go to 185.6 billion in 2026, right? There are so many connected devices. When I say connected devices, 2 million types of medical devices, which can be categorized into 7,000 device groups. Huge numbers, guys. And that is only going to go up, right? There is a huge focus on population health management, wider mechanisms. Every government across the world are compelled to look at the wider population health management. I don't think prior to Corona, we had a overall statistics around how each country is doing, how many dosage of vaccinations have been given, how many have been impacted, how many deaths, how many casualties, what is the recovery rate. I don't think we have seen anything in the past on that, right? So there would be major focus on population health management going forward. Augmented reality and virtual reality, which is a mechanisms of trying to do remotely. You can operate a machine. So if a spindle is given and when you move it using an AR, VR, it's connected to the actual device. The guy who's sitting remotely can actually feel that that spindle is also moving, right? So this is the magic of artificial augmented reality and virtual reality, where it is augmenting access to an external expertise of somebody who is remotely sitting. But of course, it should have the best networks in place, right? So 5G is supposed to bring that kind of revolution where you can instantly start calibrating your medical devices, maintaining your medical devices, and even performing some robotic surgeries, right? When we talk about electronic health records, 221 million records are shared across clinics. And this is basically a low number. It could be much, much beyond this number, but for the challenge of interoperability, which we will talk about in a bit, right? And then the healthcare virtual assistant, which is chatbots. I'm sure those of you who would have gone into some of the other industry like Go IBIBO, for example, right? The chatbot appears and says, what can I help you with? And then the chatbot actually allows you to go into the specifics of the question that you have and probably finds you an answer from its knowledge base. Similar thing is happening here already due to the shortage of healthcare professionals. So this market will reach $3.5 billion in 2025. That's the prediction. So many data points indicative of increasing apps acceptance of digital health through IOMT or otherwise is evident, and people are putting a lot of money in these spaces, and you can definitely start looking at how these things will transform in the next few years as well. So let's look at digital healthcare, and I think each one of you will be able to relate to what we have gone through in COVID-19, right? How digital healthcare was leveraged across the communities, across the countries, across the citizens, irrespective of where they are, irrespective of who they are. everybody would have experienced this. So COVID has reset a lot of normals, right? And we started calling it the new normal. Work from home is a new normal, right? So let us see different parts of the healthcare components, which you guys can, all of you relate to, right? Consumer mobile apps provided information about COVID-19, tracked symptoms, provided home fitness programs saying stay fit, right? Some people also advise stay fit before you go in for vaccination. You will not get your fevers. Your body has to be fit and fine. Digital therapeutics, right? Delivered interventions through software for select conditions, what to do in a particular situation, right? Consumer wearables, monitoring activities, whether it is your wearables, whether it is your oximeter and stuff like that. Connected biometric sensors, again, right? Oxygen saturations, levels, and helping patients self-monitor themselves. We have seen this as well. We have seen smartphone cameras where somebody having a skin allergy. I can relate to my own case where I had to report a skin allergy of my father to a doctor on Practo, and we took that, we sent the picture, and he was given a medication which cured him. But some of the times only the specialists could differentiate what medications can be given, may not be given, and they would suggest extra tests to be done if possible, and whenever possible, right? Clinical trial tools collected patient information and enabled virtual trials or trial with virtual elements, right? In-home connected virtual assistants, we still have been uh, used to getting some of these things like, BP machines and stuff like that. But these virtual assistants can additionally guide the patients to health information, uh, provide them information about a local medical help that they can reach out to. And depending on your EHR data, they can say, okay, let me push reminders to you saying that you have an appointment with a doctor next week. You need to see what is this, oncologist, or you need to go for these particular tests, so on and so forth, right? Telemedicine and virtual physician visits are there. I can relate to my pet being visited by a veterinary doctor for injection for a health condition that it was going through, right? Personal health records, the PHR, EHR, EMR, right? There's a slight difference between all of them. Personal health records were more accessible than ever online, so facilitating care continuity. So unless the doctor is given the history of the patient's condition, they may not be able to diagnose it properly, and they may not be able to give a proper medication. So a lot more people started putting their health records online in different countries, and allowed the permission for some of these doctors to access their information beyond the personal data security norms. Of course, we have seen web-based interactive programs which have delivered digital care programs, physical therapy, meditation, depression, CBT programs for insomnia, right, and other such things, right? And then care team email and text messages where people who are related to or connected or tagged to a healthcare individual can basically reach out, send a text message, and get timely interventions, timely advices, or visits even, right? So I have experienced with my old parents where we had access to a nurse who would come and give them medications, or address some of their health conditions. And the last one is health system disease management apps, which enable remote patient monitoring outside traditional healthcare settings, because the the um, the the harsh reality for most of the medical professionals during Corona times was they couldn't be as lucky as I am from a tech industry who could work from home remotely. They have to be on the ground. They are the front warriors, like the police force, like the medical healthcare, professionals who have to be on the ground to understand, address the big impact that came by. So they have also gone back to understand this disease, which was new to some of the apps. They have consolidated information and they have ensured that even in the unknowns, the degrees of unknowns that they were facing, they were giving the best possible attention and care to the patients getting impacted, right? So when we bring all these jigsaws of the puzzle together, right, it looks like this. Any comments from anybody? I thought we were said it is an interactive, so I'm waiting for somebody to comment.
Please, delegates. Dear delegates, I request you to kindly respond to sir. Dr. Venu Sampad, please.
Okay,
Over to you, sir.
okay, let's move on. So now with all the above happening, like we saw in the last slide, let us see what remains in hospital and what would move off the major hospitals, giving rise to retail healthcare, right? So this study was conducted by McKinsey in 2018, even before COVID-19 struck us. It is so very relevant and proves beyond a point that some of these studies are so deeply rooted with data, facts, and ground realities. Let's look at services that will remain in the hospital, right? Major surgery, trauma, right? Intensive care unit, inpatient admission will still remain in hospital. And retail services, that services which will move out of the hospital, right? Vaccinations, we are already seeing this happening, right? 82% of consumers have said they are willing to use retail clinics for vaccination, which happened in 2019, right? And 20, and it is still happening in 21, right? Specialists and specialist consulting has also moved to clinics, right? Where 70% of consumers feel they prefer digital solutions to phone or in-person solutions for many interactions. And 55% have used digital appointment reminders, and that number has already gone up, right? Physicals, laboratories, and imaging is something which is absolutely lab oriented diagnostics. And still, you need somebody to come and collect your blood samples, urine samples for any further diagnosis of what you are going through if there is a health condition that you suspect. So, minor procedures, right? 80% of the consumers have said they're willing to seek care for minor illnesses at retail clinics, and 40% of retail clinic visits are for minor injuries or illness. Physiotherapy, dental clinic, these are some of the examples that you can think about. And of course, some minor emergencies where you need a process. So say somebody is needing to have a catheter inserted, right? You need to go to a clinic, and that can be done very easily there, right? Now, let's look at
Excuse
five.
me, sir. Good morning.
Good morning.
Sir, is this the data relevant to even Indian market? For example, you have quoted McKinsey and Company. So is it relevant
Yes,
to Indian market? Because sir, in India, we are observing that the corporate hospitals tend to, utilize lab reports from their own setup only. They don't entertain. This is the common practice what I mean to say is.
yes. That is where we will address the interoperability challenge. The interoperability is a lack of standards. So since you brought this up, let me take it up before I wait to go to that slide. Interoperability is lack of standards which should be adhered to by every medical organization, right? If somebody is authorizing a clinic to use a report, right, then it is not basically saying that you need to do another this thing. These things happen in our country, but I think that will change the moment we bring in compliance and regulations into picture. HIPAA, SOX, all these compliance is basically to ensure and secure the patients or the citizens from these kind of behaviors. Okay, so what you're saying is reality. What should happen is basically enable the launch of standards which allow, if I have a standards, uh, a lab which is certified by the standards, then this report should be acceptable across the healthcare industry, right?
Thank you, sir.
Thank you. Okay, so let's look at, I was talking about the connected medical technology that we are talking about, the future smart healthcare systems that are getting decentralized and patient-centric. But all these connected technology solutions towards greater care has in the background implicitly built a solid data exchange and repository ecosystem, right? People sitting at home gathering data, people in pharmacy gathering data, people in the lab gathering data, nursery facility gathering data, rehabilitation gathering data, clinic gathering data, and all this data, to your point, sir, should be brought to one place, which is patient centric. Then somebody gets a total picture. In, due to lack of a total picture, if you were to go and redo all these tests, right, it leads to the CSAT of 25%, correct? Only 25% of the patients feel, yeah, I'm being cared for. But there's still a large percentage of patients who feel that they don't care about me. They care about how much money I can pay, right? And that's something that will change. But from a digital technology perspectives, right, all this data that is being collected, all this information that is being shared is so much critical for analytics that can be used to lay out a continuous plan for improvement of the care objectives, right? How do I improve a drug, right? Gather data. I see these are the trends when you give a certain combination of medications. That's what the pharmacist community would look at when you're creating a drug, right? You're basically trying to improve the drug. You're trying to improve the combination of the drug to improve the patient care. So there's so much of data that's being shared, which should be put to a good use, right? And all this is made possible, right? Where you're looking at secure and shared personal health records must be in regulatory system saying, I sign up to this regulatory and I will authorize XYZ clinic or hospitals to use my health record. Effective disease prevention and primary care, so critical, right? Targeted and better quality acute care. Even today, people still run to get a sorbitrate, even if they are facing a gastric issue. Who is going to educate them, right? Long-term chronic disease management is another thing that can be evolved from all the data that is getting collected through all these remote and retail smart healthcare. So the result, a more convenient and effective health service delivery, lower medical costs, which is basically what we have done as a nation to 95 countries, giving them the vaccinations, is basically to help them live a standard of life which everybody is entitled to. Improved service data quality due to clear roles and responsibilities. So we should know what somebody can dictate, what they cannot dictate, who should dictate what, who should drive what, right? In the absence of that, everything is hazy. People actually are taking advantage of the chaos that remains. So let's look at 5 virtual healthcare paradigms, right? The perception versus opinions of the stakeholders or consumers. The first one is enhanced care coordination. About 1 in 2, which is 50% physicians see improved healthcare coordination and quality of care through virtual care. Again, this may differ from country to country, the business objectives to another business objective, right? Improve clinical outcome. 74% adherence rate on average for heart failure medication through home-based telemonitoring, right? Otherwise, people who forget taking medications on time land up in trouble and obviously land up in ICU or trauma care centers. Now, enhanced consumer experience. 2 out of 3, which is 66% health plans, think virtual health has improved overall member satisfaction. I got a problem. Most of the health approaches that we take, I mean, even as citizens, is very tactical. I got something I wanted to be resolved now. Nobody's thinking about what are the long-term indications or implications of whatever symptoms I'm showing. So they are very happy, right? But let me ask one very critical question, right? The guys who are actually administering or writing a prescription, how accountable are they in case something were to go wrong? Don't need an answer to that, but think about it, right? Improve efficiency. Patients save about 2 hours on average per virtual visit compared to a physical visit. You travel 2 hours to a clinic or a hospital, right? And then wait in a queue. You get your token, you wait for your name being called, and then you see a doctor. Whereas everything is instant, right? We moved from filter coffee to brew instant coffee. This is also becoming like that. The moment anything is retailed, the behaviors of consumers also change, right? And the last one is expand consumer and clinician access. More than 50% of health plans member encounters are virtual. Either they will come on cam or they will be over the phone, but most of the health plans are virtual. Okay. So, madam, how are we doing on time?
Sir, we have one hour more.
Okay, good. Thank you. We are on time. Okay. So great. All this seems to be some good insights, some data points, right? So let's summarize as what it means to the technical folks like us or IT folks who are enabling all this to realize the healthcare benefits, right? Summarizing, remote patient health data monitoring, abnormality alerting has come up, right, as a benefit. Device to analytics, data stream automation, collation of data from different sources, different clinics has come up, right? Remote equipment configuration, like I said, you can use remote AR, VR kind of mechanisms to uh, recalibrate or configure or install your equipments. Virtual appliance, right? um, Virtual appliance management remotely, caregivers equipment administration, right? And timely appliance maintenance. So upkeep of lot of systems, if I can relate to availability, accuracy, connectivity, both intra and inter device, right? App management with least downtime, equipment administration, right? And timely appliance maintenance. It is beyond repair and more. I mean, if there's an improvement that can be brought in the adoption of a medical equipment, if we can improve the adoption of the medical equipment to ensure that it is fully leveraging the or exploiting its capability, that's a big education for some of the remote users of these equipments. It's getting proactive. It is about knowing when this equipment can fail and predictively give a resolution, right? And what can be quick restoration mechanisms so that the turnaround times are minimal. And data quality, which is so critical to predict the patient's reactions to drug, the particular conditions that are to be dealt with, right? So your accuracy of your equipments is absolutely essential, because if your data quality parameters like accuracy, timeliness is not in place, then you could be in for some serious trouble, in the sense that the diagnosis could go wrong, and that could be a starting point for many of the fatalities. Okay, now let's converge back. This is a very busy slide. So we converge back to our original topic of smart healthcare, digital healthcare, boon or bane. So on the left side, you will find the banes. On the right side, you will find the boons. And I have talked enough about the boons. Let's look at the apprehensions. Let's look at the barriers, the fears which are stopping wider adoption of digital healthcare or IoMT based healthcare. Okay. So some of the things that I can relate to, technology will require an overhaul of the care system, because a lot of the devices that are being used in many of the hospitals are outdated, obsolete. So it requires a complete overhaul of the current care organization as well, the care that the structure in which we are basically using it for years together, it may need an overhaul, right? Increase the risk of data misuse. As I said, somebody can interrupt, somebody can hack your data, sell your patient's data without their consent. And that could bring up GDPR kind of issues, right? Risk of spying on patients, right? Information gathered may be misunderstood by patients or their caregivers, right? Many of these are assumptions and turning out to be false, but yes, in some cases it's true, right? Alerts and monitoring may intrude in private lives of the patient, right? So intrusion in private lives, right? Then risk of hacking the devices, hacking your data is a big fear, right? And these are all barriers or fears that is stopping digital health to reach the next level. Okay. Reliability issues, right? So dematerialized information may pose problems for storage and availability, right? Reliability issues. If there is a bug in your device or equipment, it may show up a wrong data, and that could really be hurting, because wrong data will lead to wrong diagnosis, and wrong diagnosis could lead to wrong medication, right? Equipment failures could be a big issue, right? Of course, diagnostic errors is related to the earlier reliability issue, right? And then replacing the human in care is unwanted. A lot of time we say that, you know what, technology will not encompass all individual situations experienced by patients. Every patient is unique, or feels he or she is unique. They need to be treated different. My diabetes is different from somebody else's diabetes, or my heart condition is different. It could be true, but those fears can be laid away by spreading more awareness and helping the patient understand their situations much better, right? And of course, loss of human control in care is another thing. What COVID has done to every industry, just not medical industry or healthcare industry, is it has probably pulled back a little the human touch, the human connectivity from one person to the other. And that's another fear that was already allayed, saying that we fear, in case of everything becoming remote, how do I express myself, will I get the time to be able to tell my entire story? Some of the patients are very passionate about their health. They want a quality time to be given, and they will narrate their stories because they feel it is important for them. The other guy may or may not feel that it's important for them. But I have also experienced there are instances where some of the people, due to lack of time, are not willing to listen to the entire story and say, okay, I understood what you're saying, so let us do this or let us do that. So they very quickly jump to the conclusions that this is what needs to be done. Whereas that particular care part of listening, empathizing, and giving assurance could be a gap, right? Hence impairing patient giver relationship. Okay, this person, this doctor or this nurse doesn't listen to me. We have seen this in the hospitals, how our behaviors change. And very frequently we get tagged to one particular caregiver, and even in the hospital we develop some connect. Probably the bandwidths match, or the person feels, okay, poor fellow is running around, let us give him more attention. Those personal connects and empathy towards the um, other parties or other stakeholders could be missing, right? And some people feel negatively impacting patients' health behavior. Some of the people, the moment you say, oh, my fasting sugars today was 200, I don't know what I'm going through, so they start panicking, builds anxiety, builds stress to them. So when you give a monitor, sugar monitor equipment to a patient, it could build anxiety, it could build stress, and hence the BP, and hence the psychological behavior or discomfort that can be caused, right? So increasing the risk of self-medication for patients. Some people feel that I know everything, right? I have a relative who moves around with a packet of or sachets of different medicines put in the pocket, saying, since I'm traveling, I don't know what I'll need one. They're not prescribed medicines, mind it. They are thought of as treatment to some of the illnesses this person feels he has. Never got it ratified in any of the doctors, or maybe a doctor would have given him 5 years back, but still takes that as a gospel truth till today. Health conditions can change over a period of time, and hence you are advised to go and get yourself checked every year, if not every 6 months, right? And then may not be accessible to everybody. Like I said, financial factors could be limiting. There could be more accessibility to the educated groups because they learn about it, they understand, they know how to leverage this. But for the people who cannot, they don't know how to leverage it. Hence the accessibility to some of these digital health mechanisms could be very limited, unless there is an awareness, unless there is a education imparted to uh, a lesser literate people in the crowd. We have talked about improving on the boon side, the hopes, advantages. We've been talking about improving access to care, improving follow-up of patients, reminders, alerts, reducing the burden of treatment, making it more affordable. I need to pay 100 bucks only to access a doctor, whereas if I go to a clinic, the guy charges me 300. So the affordability is getting normalized, right? Improving caregivers' work, right? Where automating repetitive tasks, right? Helping care professionals monitor the treatment efficacy and side effects, and enabling more global vision of patients from the same, disease community, and so on and so forth, right? Improving prevention, primary or secondary, right? Or improving the safety of care, and so on and so forth. So this is a very busy slide. I mean, it basically entails anything and everything, and it's not exhaustive. You can continue, keep on adding to this mind map as you come across more and more, points, right? So this particular thing, it brings us back to the main topic of the discussion today. But let me go back, and before I go into the next exercise with all of you, right? I hope all of you have been listening to me attentively, right? It's not a quiz, but yeah, I will try
Yes.
to do something. Right? uh, let us look at, like I said, this is slide 12. Let us look at what all this means for medical technology companies, all the guys who are creating solutions, products, and rolling it out in the market. This is definitely not a run of the mill IT product company or a services company. The medtech companies are very focused, standards governed, compliance adhering, or compliance aware organizations that have to take care of the following 10 aspects while they are building the solutions or the products. Let's look at what they are. Developing an in-depth understanding of end users. As more providers adopt virtual healthcare models, the speed of adoption and integration of connected medical devices will increase, right? So data and insights on patients and processes is very, very key to virtual healthcare. Challenges include the extent to which an organization's IT infrastructure is prepared to handle the volume of the data, the volume of processing, and the connections that they are connected to, the insourcing connections to collect all the data. How connected medical devices are transforming healthcare to develop a deep understanding of the end user and create such business models and scenarios that demonstrate how their new and existing devices not only improve patient care and outcomes, but also create value for key healthcare stakeholders, which is all the nurses, doctors, right? So it should be a win-win for the patient and the caregivers. Second point is developing new funding, business, and operating models. As healthcare organizations focus on improving quality and making healthcare more affordable, we discussed about how to make it more affordable for everybody, right? They require tech companies to demonstrate greater evidence of value realization for both new and enhanced products. They need to ensure quality of service and providing best in class services rather than just products. Nobody buys a half-baked solution in the market. Everybody requires a complete solution. Everybody requires a thought-through solution. Everybody needs assurance that this will work, right? Different types of innovations will require different business models, and progress will depend on both the innovators themselves working in new ways to take on risks and rewards, and evolution of existing payment systems by both public and private payers. Okay. Next is understanding interoperability requirements. We were talking about this particular stuff a little earlier. An EHR or an EMR in US cannot be shipped to a UK clinic. Why? Interoperability. This is arguably the biggest challenge for the technology companies, because if you make a solution which is as per the compliance, regulatory compliance in one country, may or may not be acceptable in another country, right? Including complying with various national, international standards and protocols around the exchange and use of data. That's the biggest challenge. There are also technical challenges, such as creating an integrated governance framework in a bid to be truly a global technology, medical technology company, right? And obtaining consent for access to healthcare data. Like I said, GDPR, SOX, HIPAA, few terms which reflect this interoperability constraints. Okay. The next one is maintaining cybersecurity. The biggest concern as increasing numbers and capability of connected medical devices present additional risks of personal data security. My data is private to me. Why should I share it with somebody? It's a major concern in especially the Western countries. The scale and cost of data theft is often significant and far reaching, right? It could lead to a personal harm to somebody. All the majority would consider they are reasonably, majority of them in the sense, majority of the companies would consider they are reasonably well prepared to deal with the cyber security of their devices, which they are putting as a product. Research suggests that many stakeholders do not have a strong understanding of such risks and may eventually buy them, how to prevent them, and what to do once a risk has been identified. So you need to have insurance and mitigation for such things. In medical healthcare systems, I don't think you can do much once the risk has occurred. You have to be proactive, predictive, and stop those events which could pose a greater threat to the patient's lives from occurring. And that is the assurance the regulators will bring in, right? Regulators acknowledge that cybersecurity threats cannot be completely eliminated, and stakeholders need to work together and adopt a more proactive approach to managing risks. Adoption of security by design approach to establish real-time monitoring, cyber threat modeling and analysis, threat mitigation and remediation is needed. What are the things? Real-time monitoring, cyber threat modeling and analysis, threat mitigation, and remediation. These four things are very critical to secure a product and factor them before you build a solution or a product for the um, digital health. Okay. The fifth point is successfully navigating regulatory change. Regulatory compliance demands keep changing, and keeping pace with this is a true challenge for the technology companies. Even this is just not in healthcare; it is in financial systems as well, right? BFSI. When you go to banking, finance industry, you have all the regulatory compliance related to SUTA, FUTA in US, and so on and so forth. So these regulatory compliance changes, particularly in relation to the new European and US regulations, which keep changing in a bid to better them for both developing connected medical devices and the success of IMT is absolutely critical. You should understand what is needed so that you comply to those regulatory needs of this country. Managing the impact of regulatory change requires companies to take a proactive and well planned approach. If an innovation model is to be sustained, companies need to build engagement with regulators into their innovation model, get them to verify, get them to ratify, get them to certify your products and solutions so that you involve regulators, you involve clinicians, you involve some of the sample patients in the product design. And once you know everybody feels comfortable with that, you can go ahead. So these are typical uh, issues or challenges. I would say issues. They are the challenges that medtech companies will have to face. The sixth one is attracting digital talent and building digital capabilities in tech companies. If tech companies are to retain competitive advantage, they need to develop a new digital self-skilled or digital first skill set. A lot of stuff is being told in the past 5, 10 years about digital transformations across the industry, just not healthcare. So that includes employing data scientists, which was never there, right? Multidisciplinary talent from creative and scientific backgrounds, right? And accessing this talent pool will require more resourceful recruitment and retention strategies, including collaborations, including partnerships with diverse range of existing and emerging players, especially academia, right? Data first tech companies and innovative new startups. So the advice that I would have is I've been telling this to a lot of people from the academic industry that try in the digital space, right? Try to develop more cohesive coupling with the academicians so that you have people who are already in a research mindset to start mulling over your new product design and help you come up. Or if you are a corporate, you can provide wings to some of the innovative ideas they can bring to the table. The connect between industry and academia is only going to show synergies in speed tracking the solutions for patient care, better patient care rather, right? So how connected medical devices are transforming healthcare, creating an effective IOMT at scale requires collaboration, partnership between patients, providers, payers, pharma, academia, and other medtech manufacturers, right? And other research identified multiple case studies that demonstrate medtech's important role in IOMT and the conditions that have led to adoption of connected products and services. Adoption is critical. It's just not that you throw out some solution into the industry and industry will simply consume it. No, they are in the life-saving game. They cannot afford to take anything which does not come with a guarantee, not even warranty, guarantee, right? So your solution has to work. Your solution has to be reassuring that it will deliver the outcomes for which you started this product with an objective or a solution. Now, collaboration between healthcare providers and medtech for effective deployment adoption is very critical. Now, what I'm basically trying to say here is if you collaborate between the various stakeholders, when I say stakeholders, everybody who is putting their skin into the game, right? It is just not the patients, it is just not the doctors, it is just not the nurses, it's just not the pharmacists, right? Everybody who is basically integrating connected medical devices into established care pathways is challenging. And this requires significant cooperation across the IOMT ecosystem, right? Collaboration strategies such as partnerships, joint ventures, venture capitalists being brought in to fund a typical idea that could evolve into a product or a solution is so very critical. And that will help ensure effective transmission, aggregation, analysis, and management of data from connected devices. So much of information, what are we using it for? So these collaborations allow stakeholders to improve their understanding of the patient needs and deliver more proactive, cost-effective care. At the same time, right, there is a big factor called trust. Okay, trust in digital age has to be maintained. The connected medical device industry is catching up due to more IoT capability enablement. And traditional medical device companies are becoming more and more involved in data management and analytics. But consequently, as tech companies develop strategies and services based on generation and transmission of patient data, they need to ensure they demonstrate clearly to patients, the public, and healthcare professionals that the data that is being collected are actually protected and used responsibly, right? They have to undertake the safety and security and confidentiality of all the data that they will use to deliver solutions or products to the betterment of patient care. Onus is to develop key principles of consented secure data management. Consented secure data management means give patients control over their own data, including the right not to share. I don't want to share, fine, but you cannot forcibly take. The level of data privacy today in every country, it's just not India, when how much you get annoyed when somebody calls you and says, I'm calling from this bank, you want personal loan, right? Imagine if we were to flip it to the healthcare side and somebody called you up and said, hey, I think you have got diabetes. Would you like to have a better treatment? What would that do to your mindset? Not acceptable. How does this guy know that I'm diabetic? How does this guy know I'm having stress or I'm having depression? So that trust is so critical. It is just not the protection of data that I'm talking about is somebody hacks into it and gets into these details. they automatically will start reaching out to patients directly and say, we have a better healthcare plan for your diabetes or for your BP or for your dementia or whatever it is. It is so very annoying, right? At the same time, improving the adoption of medical technology at scale, unless we ensure that healthcare organizations, clinicians, and patients understand the added value of connected medical devices and use them at scale to drive better economics and patient outcomes. Both are critical. Better economics and patient outcomes. The task will continuously remain uphill because 80% of the time, instead of spending on product innovation, solution design, you will end up spending that effort into convincing people that this is good for you, right? So difficulties include lack of governance, standards, like I was saying, and sufficient robust evidence that demonstrate that connected medical devices are more cost effective. They're still struggling with this. The medtech companies still struggle to say these are great ideas, but what will be the platform on which they will be delivered to the customer? Android phones, what is the total coverage of the Android phones, right? Don't look at globally. Look at some of the countries which are densely populated, like India and China. How many can afford? How many have real access? And there are diameters and such products and companies which are probably delivering the same solutions, right? And this next one is connected medical devices benefit patients, providers, and payers. You have to ensure that partnership with healthcare providers allow tech companies to understand the clinical context in which devices are to be used. They should understand just not clinical context, right from what a pharmacist is looking for, what a P2M, what a pill to market periods are, how do we improve everything, right? In Corona time frames, I think we all were never sure that the vaccines would come out so soon, because the clinical trials that are needed for rolling out any medication in the field is very, very long in terms of the timelines, right? So adding connectivity to a device allows data to be generated on a patient's condition and effectiveness of the healthcare provider's operations. That's the expectation. How much does it collect the accurate data is only left to the quality of the product, quality of the platform, quality of the device. So being able to quantify, contextualize, and communicate these interactions allows the tech industry to provide solutions that deliver value to all care stakeholders, all healthcare stakeholders, irrespective patients, doctors, nurses, whoever, clinicians, everybody, right? And then joining the dots between connected medical devices and healthcare IT systems. A number of large tech companies have developed connected ecosystems that act as a common platform to share, aggregate, and view data to drive clinical and operational value, right? Connected intelligent medical systems. I mean, there could be, you can name it whatever it is, but the baseline is you are basically connecting devices to gather data and use it to arrive at patterns, use it at arriving uh, inferences to what could lead to a better drug, what could lead to a better treatment. Linking disparate sets of data that sit within health organizations or healthcare organization is central to achieving connectivity at a scale. There's no point you're just connected, but you're gathering disparate data which is not integrated. So applying advanced analytics to the generated data from connected medical devices to provide critical insights and empower better decision making. Mining, managing, analyzing a vast array of data from medical grade wearables, talking about standards, right? connected imaging devices and monitoring devices a key part of deriving value from the IOMT and IMT based medtech companies. The last point is tech services that demonstrate improvements in patient outcomes and reduce healthcare costs. Tech companies are increasingly looking at sophistication of connected medical devices, improved interoperability across healthcare organizations, and advances in analytics to develop service-oriented solutions. Everybody is saying, because I need to deliver a value-based solution or a proposition, I need to have interoperability resolved, right? And hence, I will develop a service-oriented solution. Now, imagine building standards-driven medical device platform pairing. You cannot pair a disparate standards equipment. That could be the next thing. Think of services including managed catheterization laboratories and transformations from a product manufacturing to a healthcare provider, right? Helping improve patient outcomes, obviously, and reducing the cost of healthcare. That's the two things that everybody is targeting. But if you were to have the clinics, I can tell you, I think almost 10, 12 years back, I was putting a solution together for um, the series of clinics in Saudi. King Abdullah Institute of Medical Research. That was what we were working for. And the solution that I was working on or creating was to provide an integrated medical platform which will combine all the clinics and get their pathology lab test data to a central point where a department of neurology or department of oncology could bring the data, correlate them, analyze them, and understand the symptoms, the care, the medication, the reactions, the drugs, right, to be streamlined, right? I'm sure 12 years later they still have that, but we are still talking about the same stuff, right? The insights generated by linking connected medical devices and health data sets can play a key role in aiding health systems to reduce costs, improve quality of service, identify populations at risk, connect with consumers, and better understand the performance. Unless I understand the performance of the solution that I've provided or product I've provided, I cannot work to improve it further. And you have to take everybody on this journey together so that the focus is more affordable quality of service without any compromise, which is going back to my first slide saying digital health at what cost, right? And there is enough competition already in the market. So anybody who's starting fresh must always look at the pros and cons of stepping into somebody else's toes. So there are 40,000 mobile apps which are doing a lot of these things, but how many are basically trying to get into the nuts and bolts of ensuring a satisfied patient outcome? Okay, I'll,
Sir,
yes, madam,
there is a question in the chat box.
sure.
Could you please explain digital healthcare system impact on policymakers, sir?
Yes, interoperability. I'll go back to the same thing, right? Unless you have your standards, right? And I will draw a very quick parallel to that, what I'm saying. Unless you have, the policy makers do not create a policy which must be adhered to. I can give a prescription as a doctor, right? But if the patient doesn't adhere to that, right, it is not going to be successful. My treatment is a failure. Similarly, if the policy makers are creating a policy which is not getting adopted, right? And please go ahead and create, if you're a policymaker, you should create tough policies that secure the patient from his or her data being spread across on pamphlets like this, right? One, impose heavy fines or penalties on organizations which do not adhere to. I'll give you an example. IRDA, which is the Insurance Regulatory Department, right, or authority for India. If you do not comply to their rules, the insurance provider's license can be cancelled. Unless we make those rules, the other gentleman was talking about, the problem of one hospital not accepting the lab results from another lab, right? Those kind of policies will help interoperability and make the lives of people like us much easier, because an application, you have used Ola and Uber, right? Ola and Uber in Vizag or Calcutta or Bangalore or Hyderabad or Delhi is all the same, right? That standardization, if it is not brought in, the tech companies can only align to what you are asking them to do, right? They're not seeking freedom to do anything. They're basically saying within the given confines of the policy regulations that you have laid out, I'm providing my solution or the product, right? So policymakers are very, 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 very critical to this entire game. Otherwise, I've created, would you take this? The guy is thinking, what is my risk taking appetite? But if everything is framed under a policy, then the giver and taker both are secure, and most secure is the patient. Does it answer your question?
Yes, sir. Absolutely. Thank you so much. And we have one more query, sir.
Please.
Can you please explain how digital health makes patient-centered healthcare?
Digital, sorry, just repeat
Uh,
that. Digital
can you
health.
please, yes, sir. Can you please explain how digital health makes patient-centered healthcare?
Again, it is basically you are giving the control. If I go back to the slide that I was talking about, right? I don't know if you gave sufficient attention to this particular slide. You are providing access to their own health parameters, right? When you have a BP monitor and you are doing a regular scheduled BP check, you know what is my BP in the morning, what is after my eating, breakfast, dinner, lunch, right? I know how my heart is responding because oxidation improves after you have your food. So you should know how your pulse rate is, how your BP is, right? That's one thing. Digital healthcare also talks about sugars, right? The sugar machines that you have, whether you use a Libera or not is up to you. But those are things. When you feel low on oxygen, right? You are basically using oximeters. Oximeters have caught up in the past 1.5 years so ferociously. Every house, every alternate house at least, has got an oximeter to check how much is my pulse, what is my oxygen rate, right? So these things are actually allowing the patients to understand their health parameters, their body behaviors better. Well, some of the things cannot be, totally ruled out. Like if you were to go for a complete health checkup or complete blood picture and say, okay, I need these 13 types of blood tests, you still need the person to come and take the sample, which is something which you cannot do remotely. Anything that you can do remotely, otherwise the lab reports that comes to you via your WhatsApp is again electronic digitized report, right? So it is slowly implicitly giving one control of your health, to understand what you can eat, what you can drink, what you should not do, when to take your medications, when not to deprive yourself of sleep, when you are stressed, when you need to cool yourself off, right? All those things are being self monitored. Nobody's telling you these things. You are trying to understand your body better through all these things, right? At the same time, the larger part, which the medical fraternity was doing earlier, of telling you what to do, keeping an eye on you, is being done by you while they are busy trying to devise, infer, analyze the data and the products and solutions that can make your lives further better. Of course, medtech companies are via media to create those things, but the medical healthcare system is going up in terms of the value chain, right? Otherwise, let's say you've got old people at home, right? And you're obviously every time worried. Probably 4 years, 5 years back when there was no corona, you would visit the hospital or clinic every week for regular care. And with the kind of scenario that got built in the subsequent years, that if you step out, right, you may get corona, right, has forced you to become what our PM calls Atmanirbhar. And to become Atmanirbhar, you have actually leveraged lot of digital equipments, right?
Thank you, sir.
I hope it answers your question.
Yes, sir. Sir, we have a couple of the questions. Can I?
Sure,
Or it
sure,
will.
sure, sure,
Thank you,
sure.
sir. Thank you, sir. Sir, please explain the digital healthcare future perspectives and its impact on society.
Fantastic. I will come to that slide in a bit.
Sure,
Okay.
sir. Shall I go ahead with next question,
Yes,
sir?
yes, please.
Sir, please explain how do we ensure privacy in the avalanche of digital solutions that surround us? What about the people who are criminalized and otherwise marginalized?
I don't know what you mean by criminalized, but yes, security is absolutely, absolutely a concern, right? When I look at what are the penalties for people who are using your data without your permission, the first question that I will ask is who is stopping you, or who is stopping them, rather, not you. Who is stopping them from using your data? If you go back to GDPR, in my organization, there's something called GDPR, and we are all signed up for that. Nobody can use any of the employees' data in any of the countries, my company being global, any of the companies without my permission. Even my phone number, even my mail ID, even my blog sites, nobody can use it. Okay. So the issue is who is driving these compliance? Who is driving cybersecurity laws? What are the policymakers advising, right? What policy decisions are taken to spread the awareness to people that their data can be misused, right? So charity begins at, our home first to start with, but at the same time, charity also begins at the state agencies, which should say, no, you cannot use the data without a written consent of the patient. Today, we take a file, right, got from hospital A or clinic A, take it to hospital B or C, and show them that, hey, this is what my history says. And the guy looks and says, probably this is 3 months old data, so you should get your test done again. The patient may not be even aware that these vital statistics are valid for this period. We're simply going getting our test done, and somebody says do it once more. We are going ahead and doing once more. Why? Because we feel that the first of all, the shift is a reflection of trust deficit, shifting from one doctor to the other. The second thing is, in a bid to get a better fellow who can take better care of you, you're ready to invest. Correct?
Yes, sir.
So not many people are aware, or the awareness is not there as to how do I say that, this data was taken only last month, right? And my HbA1c is this much. right? You are asking me to do another HB1AC, right? Which doesn't make too much of a sense because it is only 2 weeks that has passed from the last report. So data privacy is something which the policymakers should include and enforce through state agencies. Helps? Does it answer your question?
Yes, sir. Yes, sir.
Okay,
Thank you so much, sir. We
thank
move
you.
to next question.
Sure.
Sir, can you please explain what will be the role of hospitals in future? How will be the patient journey? How will the patient journey change?
Well, I think I already covered what will remain in hospital and what will move out of hospital in my slide. I don't know if you were seeing that slide, but lot of the trauma care, surgeries, major surgeries, right? And some of the other things which are there in this slide. Let me bring it up once again for you. This one, sorry. You can see my slide. Major
Yes, sir.
surgery, trauma, intensive care unit, inpatient admissions will still remain. So you will gradually move from personalized health care or personal health care at home to clinic and then to hospitals. That would be the journey that will follow.
Thank you, sir. Sir,
Okay,
yes, sir. Next question, sir. Sir, won't digital medicine lead to the exposure to additional risks?
it will.
Okay, sir.
It will, but depends on what is the risk you are referring to. Okay, today we are saying endoscopy is a very painful process. But have we not started using EPIL, which is a capsule with 4 cameras, which is inserted into your mouth? You gulp it like any other capsule, and it takes the entire picture of the track that it is going through your food pipe, your intestines, till it comes out and tells you how your system looks like, right?
Yes, sir.
So there's innovation that's happening. You should appreciate, adopt, and promote with, of course, all the T's and C's in place. The terms and conditions should be very clearly put in place.
Thank you, sir.
Shall
We
we
will.
move and finish the slides and then come back to questions? Otherwise, I'll be half done.
Sure,
How
sir.
much time do we have?
Uh, till 11 o'clock, sir. But anyway, we have still half an hour gap is there for the next session, so we can make use of that, sir. No problem.
Okay, we'll come back to that. Right.
Sure, sir.
Let's go to the next one. Right. The pandemic has actually, taken us to build more intelligent solutions, or so we call. But let's look at the market potential by 2026. Robot assisted surgery, which one of my friends does. She is a top gynecologist in Telangana, right, for Apollo, right? They do robo assisted surgery. That market is at 40 billion by 2026. Virtual nursing assistants, HVA, is standing at $20 billion, right? Because of the medical labor or medical workforce shortage. Administrative workflow, easier integration with existing technology infrastructure without throwing away the old ones. Those integrations will still be invested on, and that market stands at 18 billion. And fraud detection, of course, what you pay, your insurance, your medical bills, those things, because the medical expenses are shooting through the roof and there's so much of transaction happening, right? That is the next vulnerable space, and hence the fraud detection industry will need to be looked at for a $17 billion opportunity, right? And the last one, dosage error reduction. There could not be anything more fatal than a dosage error. So prevalence of medical errors, which leads to tangible penalties. And this is to my policymaker friend sitting in the panel, that unless you have a properly defined rewards and penalties encapsulated in the framework of the policy regulations that you craft, people will not be scared of administering anything and everything. Okay, that leaves them to become that much more commercial in their behavior, and the patient care gets a lower priority. So these are top things that I would talk about, top 5 industries, and the rest you would have already read from. The last one, somebody asked, healthcare 2025, right? Pandemic has compelled the use of techs such as telemedicine to enable forward triaging that allows patients to be efficiently screened without face-to-face contact as the first step. It also enables self-quarantine of patients who do not need hospitalization through the provision of continuous monitoring and support. Not only it protects the patients, but also clinicians, hospital staff, and community at a large from the corona kind of virus. It can allow physicians and patients to communicate 24 by 7 through WhatsApp, through whatever digital social platform, right? Using webcam based computers like what we are using now, right? And to monitor symptoms on a regular basis. Fortunately, telemedicine networks have currently been established in many countries, incorporated into clinical workflow during the corona outbreak, and shown to be feasible, effective, and efficient in sharing epidemiological data, enabling direct interactions among healthcare professionals and providers or patients across the distances, minimizing the risk of SARS-CoV spreading, right? And improving still the access to patient care. You're still monitoring and still taking care of the patients while you are minimizing the risk of the spread. So coming to India's telemedicine market, it's expected to touch $5.5 billion by 2025. And this is all researched, established, published data, right? Spurred by a rise in teleconsultations, Practo, and all those things are there. We will come to some of those very quickly. Telepathology, teleradiology, and e-pharmacy. So due to the pandemic and the subsequent lockdown, this has resulted in significant growth in the number of telemedicine platforms in the country, right? Startups such as My Health Care, Meadow, Docon, Pebble have been added to an existing list of players like Practo, Amfine, Mfine, that is I am fine, DocApps, Call Health, right? Call Health is again Mr. Ramling Raju's organization, and Liberate, right? The future of telemedicine will depend greatly on creating effective ecosystem of care, not product, not independent solution, not one-off kind of stuff. It's an entire effective ecosystem that has to be created around the patient. And that's why we say patient centricity, which will just not connect the patient and doctor, but in addition will be able to use technology to assist with delivery of medicines, right? I don't know how many of you know 1mg recently got acquired by Tata. Diagnostics, delivery of medicines, delivery of diagnostics, getting reports back, and all this being tracked by doctors on their EMR. EMR platforms are many. Various doctors use different kinds of EMR platforms. So emerging startup My Healthcare has been working with their partner hospitals in creating such ecosystems of care for the future. Okay. Access to quality primary care has been a perennial problem of the Indian healthcare sector. A report by the Center for Disease Dynamics Economics and Policy, CDDEP, in the US, right, outlined that India has a shortage of around 600,000 doctors and over 2 million nurses, right? Reports highlight that India has a further shortage of 150,000 radiologists, right? So pathology companies like Dr. Path Labs, Thyrocare, Pathkind, laboratories have created platform integrations with telemedicine platforms to help process home sample collections, getting their reports back into the patient platforms and delivering the same in real time to the EMRs for doctors to review and update the patient's care. At the same time, if they are all connected, the patient, the pathology, the medical stores are all connected. The moment there is a prescription written, it should go to a medical, drugstore, and that guy should pick up the responsibility of delivering the medicine in the prescribed quantity as per the dosages. And very, very powerful ecosystem can be built, especially for old people who are on their own and trying to drive the monitoring of their health on their own, right? Now, with the changing behavior of patients and doctors, increased penetration of high bandwidth mobile internet, digital healthcare consumption, and the country's proliferating startup ecosystem, the teleconsultation market alone is expected to touch from 100 million today to 700 million over the next 5 years. It's a clear rise of 40% in the potential. Okay, so the advent of 5G that is coming in or has come in many areas, but still being tried out. AI and machine learning will accelerate this further, making more precise decision-making mechanisms to be put in place for helping patients being looked after in a much better quality of service. Okay, next slide, and we come to the final circling back to, is IoT, IOMT, or medical or smart healthcare, whatever you want to call it, digital healthcare, a boon or a bane. So let's discuss. What I am doing here is this is the slide. So madam, I will request you for helping me taking notes on your copy of the slide that I have
Sure, sir.
given to you, right? So what I would like to do is, for all that you have heard me blabbering for such a long time, right, during the course of this 1.5 hours, 1 hour 45 minutes, let's take down points on boon and bane. Boons are the positives, bane is the negative. So please put down, please come on to the call, right? Announce yourself so that madam can take down the participant name and let us know what is the boon that you feel smart healthcare, digital healthcare, or IOMT is providing to the patient care. And if not, what is the risk or what are the fears or barriers that you have understood from the presentation so far? Let's be very quick. We have just 10 minutes, not even 10 minutes, probably 5 minutes. I think with so many
Yes, sir.
points that has been given, let's do it in the next 5 minutes. And even if you're able to reach 5 each, I'm fine with it.
Thank you, sir. Over to technical team.
Yes, ma'am.
Please feel free to chip in with your thoughts. Please identify yourself and 2 lines about what you do, and then you can talk about the boon or bane. Let's restrict to 5, madam. I think we're running out of time.
Yes, sir. Sure, sir. Dear participants, please.
And guys, I was told this is a very interactive group. So let me see the interactions coming up.
I request the delegates to kindly respond.
Good morning, sir. I am U.
Morning.
Harni, sir. I am working as assistant professor in Venkateshwara College.
Yes, ma'am.
I think artificial intelligence is sometimes useful, such as whereas I know, like Arogya Setu apps during COVID. Sometimes these apps are really working. People around us, we can know who is positive. But if the patient is not registered or they are not using the apps properly, so even if the person is next to us, we cannot know that they are COVID positive, sir.
Correct.
So sometimes it can be a boon to us, but we are not following it properly, sir.
Yeah. So the solutions are given to you. It's like a bike being given to you or a car being given to you. If you don't drive, it could be hazardous to the others, right?
Yes, sir.
Very good point. Thank you, ma'am.
Thank you, sir.
Next
Hello, sir. This is Sukhwant Singh.
is Sukhmanji.
Namaskar, sir. Sir, technology can always be, can have a lot of glitches. There can be bugs. There can be, hacking. There can be encroachment into privacy. So these are all banes of the technology. But at the same time, when it helps us, it cuts shorts our time. It helps us manage. It gives us real time information. Then of course it's a boon.
Fantastic. Fantastic. Thank you, Sukhmanji.
Thank you, sir.
Next.
Please, dear delegates, we are running late.
Come on, this is not rocket science.
Yes, sir. It's a boon, sir, because it is a boon. That's why we are talking to you. First thing, we have a digital platform here, so because it is a boon, we are able to communicate. Or else, myself, we are at some other place and we cannot come and join any sessions. It's really a boon to everyone. I think so.
Okay.
Hello.
From a healthcare perspective, what do you see is the
Yeah, all
advantage?
emergency cases, sir, it is most useful in all emergency cases, sir. Like our 108 service or that she team. In many cases, it is most useful, sir.
Can you please identify yourself, ma'am? I didn't get your
Yeah,
name,
I'm
sorry.
Dr. Vijay Lakshmi. I'm Dr. Vijay Lakshmi, sir.
And you are in Andhra University.
I'm,
You are where are you?
yeah. No, sir. I'm from Guide School of Pharmacy, Rajahmundry.
Okay.
I'm working as professor at Guide School of Pharmacy, sir.
Thank you so much, ma'am.
Thank you, sir.
Anybody else? There are 40 people and we are not getting 5 points. So I don't know whether I was communicating properly.
Sir, it was so crystal clear. Even, whatever the queries we were getting, in the next moment we were talking about the same thing. So, like we thought our vibrations are reaching you. It
Good.
really, it's a fantastic lecture, sir.
So I'm still waiting for 2 more points. Let's get 2 more points and then we can move on and come to conclusions. Anybody?
Sukhwant ji, kindly, I request anybody quickly. Yes, please.
So we all have actually understood, but I don't think participants are getting enough points because you were crystal clear. So we have understood well. So please don't take it otherwise because I know all of
No, no, no,
yeah.
no, no, that's okay. So if we are fine, then we will move on, right? So let me
Sure,
quickly summarize, right? Um, the top 5 merits that I see, More IoT enablement means faster access to data from a provider or from the tech companies. More knowledge base being built because a lot of information coming in, a lot of facts being circulated, lot of knowledge that is getting improved even in the common citizens or patients. Access to ratified specialists, which was very, very difficult. We used to have appointments fixed up and then you would wait in the queue, but before you start waiting in the queue, you have to travel. Your token number is called. You're not able to reach the hospital in time, so your token, your slot is given to somebody else. Your delay or waiting period gets elongated, right? All the nuances associated with physical, visit to the hospital. So unlike that, you have ratified specialists that you can reach out to. So the accessibility has improved. Predictive care through analytics, I think a lot of data aggregation leading to a lot of analysis and helping people to proactively say what you can do, what you should not do, and what you should avoid. And of course, there are less apprehensions. Before you go to a doctor, you would think 10 times whether I should go. I don't know what he or she will say, right? What they may come up with, what tests they may subject me to, what other investigations can be unleashed on me. So that fear has subsided. But the challenges, obviously, the data privacy, the data security is a challenge. In-person care is still inevitable, right? You still need those hospitals to give you a total care. Affordability of wearables or devices, as we discussed earlier, is still a concern unless people are getting an Android phone for 1,000 rupees, right? It cannot become that much more affordable. Standards and accountability missing. That is again an onus on the policy decision makers of each of these countries, right? Which should be able to drive, the policy, even in the states, right? We should come up with some real good policies, real good strategies around protecting personal data of patients from being flouted in the public, right? And the risk, are we blinded by quick turnaround times because I need something immediately at the snap of my fingers? Am I misusing the opportunity where I should have not gone in for tactical treatment, but a more holistic treatment? So this could be, I'm avoiding a holistic treatment to my, illness by doing a quick fix, which could be very, very detrimental in the long run. Okay. I will bring up some leading companies which are investing heavily to further bring in disruption to the medtech world and playing in different segments, mostly sensor-based technological transformations. You may not find all the companies, but this is a sample, right? Top technology companies that you should look out for. If you look at imaging and diagnostics, right, you can look at some of the Zebra, Lunet, right, DX, and so on and so forth. Looking at drug discovery, right, Blackthorn, right, Benevolent AI, Finch Therapeutics, right, Spring, some of these things are there. Predictive analytics and risk scoring, Bensai, right, Ikeo, Welltalk. Then you have genomics. So Decipher, Sophia are some of these guys. Fitness, of course, we have VI, Finch, Garmin, all these guys who are coming up with wearables. Hospital decision support, right? Binary Fountain as one organization. OMI, Lean Tasks, right? Medical, Next Health. Virtual assistant, which is all the chatbots that we're talking about, Boy, Notable, Suki, and there are a lot of them which are being made by companies which are still there, but they could not make to this list. And then you have clinical trials, nutrition, compliance, and mental health. So there are lots of companies which don't feature here, but these are the various segments where technology companies are focusing on and trying to build a more robust healthcare solutions for all the patients. Okay. So that brings us to the end, and we can start with any questions or feedback or deliberations that you have. So, Madam, you can go back with the questions that you were having to ask.
Sure, sir.
Sir, I would just like to put up. Sorry, I'm speaking
No,
out of
no,
turn.
no. Please go ahead.
Yes, sir, I would just like to interject and put up a point. Like, for example, when I teach in pharmaceutical chemistry lab virtually, you may be able to relate it with the clinic as well. That
Yeah.
suppose I'm posing a question to the student, or I'm giving an example that, for example, this particular chemical, it is pungent in odor. So he's not able to smell it when he's present virtually, or when some teacher tells that this texture is smooth or it is
Yeah.
rough. Similarly, when the patient says that, my wound is smelling of XYZ, whatever may be the case. So virtually it is not possible. It is a very big
Yes.
inhibition for all the
Yes.
students, the patients, the doctors, the teachers as well. So
I think sensory organs are not, the technology has not yet reached a stage where sensory organs can be the look, the feel, the smell, except for the vision, because you have a virtual eye in the camera, right? Except for that, I don't think we have advanced technology to quite an extent where you can bring in sensory organ experiences to the laptops, desktops, or apps.
so we still have miles to walk, right, sir?
We still have distance to cover.
Thank you, sir.
Thank you.
Sir, one question. Digital healthcare patient caregivers played a key role in and remote areas during the pandemic to counsel the public. Develop such models to cater the needs of the public in contaminated pandemics.
Absolutely. I think sometimes the necessity is the mother of invention. I don't think we would, if Corona was not so severe, we would have reached the vaccination stage so early, right? Everybody wants to um, do things in a very calibrated fashion. Why I say calibrated, you should, this is something to do with the life and death of people. Whatever you do should be done with sufficient caution, care, and understanding. Never rush through doing something which can be a temporary solution and can have larger backlash, especially in this industry. And hence, medtech industries are very different category. They have to have so many factors that should be taken into consideration before they come up with proposing any solutions. Yes, it's a good thought, but then let's say we are talking about 40,000 mobile apps, right? How many of you know even 10 out of them? You're all from the this industry, right? My question is, how many of you know at least 10 of them? If I were to ask you to name 10 apps like this, I'm sure many of us will not be able to do it, right? So the awareness or the lack of awareness is something that we have to address. Affordability in terms of trying to give the access to the medical health care through the MApps or the mobile apps is very, very critical. But at the same time, right, is also very critical. It cannot remain in the hands of only educated people. It's very, very wrong to starve the illiterate crowd out of the advantages that this particular segment brings in. Does it answer your question?
Thank you, sir.
Thank you. Any other questions?
Sir, I have another question. Do
Sure.
we have a yes, sir. Thank you, sir. So, do we have a database in India which can, be a guiding document for all of us in this regard, or is the Indian government coming up with any policy related to this?
Not sure. Maybe you should put it across to the Ministry of Health into their inbox and see what they have to tell.
Right. Thank you.
Thank you, sir. Sir, without any further delay, if we have a couple of the questions to WhatsApp
Sure.
chat and here also, but we will forward all these things to your mail and later we can see. I
I
think
have,
you are
Madam,
getting, sir.
I have another 5 minutes. If you want to take up any questions, I'm free with it, unless people have to rush out.
Sure, sir. Sir, which technology will reshape the capability to care for patients remotely and from home?
Well, I think most of the programs are all in there, right?
Yes.
Most of the your WhatsApp could become a very revolutionizing stuff because it is already having the reach, right? I heard that WhatsApp is also going to start payment soon. If WhatsApp could also, somebody could tie up with WhatsApp and start spreading the medical, telemedicine kind of healthcare benefits across, well, that could be transforming. It's just an idea away. It is for you guys to understand what you want to create. If there are people from that field who want to create something, yeah, best way is tie up with WhatsApp
Thank you,
and
sir.
the likes. Yeah,
Thank you, sir. Sir, last question.
sure.
Greetings, sir. Will you please explain the role of robotics in surgery?
Well, robotics is just not the physical robotics, right? Um, you can talk about automating the prescription inferences from the parameters collected from the patient to a real robotic surgery. When I say robotic surgery, you basically put on an equipment which is connected through high bandwidth Wi-Fi in another place, and then you can do the surgery remotely. That could be the spectrum of what you can automate, and those could be from soft bots to hard bots. But everything gets driven by a software program and platform. Infrastructure has to be strong, and those days are not very far when people sitting in Pune or Mumbai or Hyderabad could do a surgery back in Calcutta or Chennai or Bangalore or vice versa.
So, a quick interjection just here. It's of course a personal question to you directly. Being a republic in India, and we have both capitalistic as well as socialistic things. Now, a part of country which deals with famine and which deals with lack of food, shortage of everything. Do you think we are all ready for that infrastructure to be developed in India at cost of addressing other major questions in the country? It's a personal question, sir. You may choose to deny to answer, sir.
I can choose to deny, but जान है तो जहान है. जब जान ही नहीं रहेगी,
Right,
right?
sir.
So जहान कहाँ से आएगा,
So the
right?
first question needs to be answered is the to addressing the bigger questions.
Yeah, that's basically a bigger responsibility, right? Which the government is anyway trying to take and address it continuously. But at the same time, providing affordable healthcare is also our responsibility, correct? As a nation.
That's true, sir.
So eat healthy, stay healthy.
Thank you, sir.
Thank you so much, sir. Thank you.
Thank you.
So, with your permission, sir, may I conclude the
Sure,
session?
sure. Thank you so
Thank
much.
you. Dear sir, Sairam Bolla Pragadaji, thank you so much. We had a great session on digital health and smart healthcare, a boon or bane. Sir, your talk constitutes Internet of Medical Things, preface of digital health, healthcare emerging facts and trends, healthcare market trends, digital healthcare at home in COVID-19, instituting consumer wearables, connected biometric centers, smartphone cameras, clinical trial tools, in-home connected virtual assistants, telemedicine, virtual physician visits, personal health records, web-based interactive programs, K-team, email and text messages, health system disease management apps, consumer mobile apps, digital therapeutics, retail healthcare, decentralized and patient-centric healthcare, five paradigms of virtual healthcare, Internet of medical things, healthcare benefits, hopes or advantages, improving access to care, improving the follow-up of patients, reducing the burden of treatment, improving caregivers' work, improving communication in care, improving prevention, improving in safety of care, economic and environmental friendly, accelerate research, and you discussed about the barriers or fears, increasing the risk of data misuse, including the patient's life, risk of hacking, reliability issues, replacing the human in care in unwanted.
Yep.
Sorry. And you discussed about replacing the human in care is unwanted, impairing a patient's caregivers' relationships, negatively impacting patients' health behaviors, may not be accessible to everyone. And you spoke about the top 10 mantras of medtech or IOMT companies, 10 top AI applications changing our smart healthcare, Healthcare 2025, the digital healthcare ecosystem, Internet of Medical Things. You spoke about standardization of smart healthcare merits, more IoT enabled faster access data, more knowledge based access to ratified specialists, predictive care through analytics, less apprehensions, challenges like data security, privacy, emergency in person care, inevitable affordability of wearables or devices, standards, accountability missing, blinded by quick chat. So these are all the various inputs you have given us throughout this 2.5 hours lecture, sir, and you have clarified all the queries of our delegates. Like personally, what I felt is we were sailing on a silent river, we were right your entire session was like mesmerizing. We were trying to capture whatever you are telling, and rather I felt one more thing is I felt like a professor. So how rather than an industrialist. So that's my personal opinion. I don't know about the delegates. Can anybody please respond?
Yeah, please.
Yeah. So
Any feedback is welcome. So please let me know.
Good afternoon, sir. Good morning,
Good
sir.
afternoon.
This is Vijayalakshmi, Dr. Vijayalakshmi. Sir, it
Yeah,
is
madam.
a very elaborate session, sir. Very elaborate. Each and everything you have explained so nicely, and we understood each and everything, sir. That's more important. You can say many things, but we have to be capable of understanding you, sir. But we each and every, I think most of the participants must have understood each and every point you told. Thank you so much, sir, for this elaborate session.
Thank you. Thank you.
thank you, sir.
Thank you. Thank you
So
for
we
the
all
opportunity.
are new for the AI and IoT, but we are all trying to inculcate all these inputs by all the speakers throughout these 5 days, and definitely we are not. We have gained lot of things from this FDP, and after we are not leaving here all the sessions whatever we have imbibed. But we are going to. I mean, we already so many people have discussed in the ATAL WhatsApp group that, madam, we got this kind of research idea and that kind of collaboration we can do. Like that, we are getting the feedback from the delegates, sir. So definitely, we will. We are. Pretty, fortunate to have all of you from the big industries. Thank you
No,
so much,
the,
sir.
the pleasure is mine. I think I should thank all of you for patiently listening in, right? I could bring the best what I could, right? I'm not a pharmaceutical or medical professional, but I span across all the industries from IT solutions, products, services standpoint. So I can relate to a lot of these things. So I hope this session was knowledge imparting and was beneficial to most of you. Please feel free to reach out to me if you have any queries or any questions for me. I'll be more than glad to answer them. Right. Thank you so much, ma'am, for this opportunity. Once again, I thank the AICTE, the ATAL Academy, and Andhra University, my university, for bringing me this opportunity. Thank you so much. Have a
Thank
great
you so
day,
much, sir.
all of
Have
you.
a nice day.
Thank you.
We'll meet you in valedictory, sir.
Sure. Thank you.
Sir, we request you to stay for only 1 minute. Okay, technical team.
Yes, ma'am. We request all the participants in a video mode. So here we go. 3, 2, 1. Thank you. Thank you, ma'am. Over to you.
Thank you so much. Dear participants, we'll have a short 5 minutes gap for the next session. So I request all of you to kindly bear with us. And we move. Now the time is exactly 11:30 here. And we again rejoin with a very short 5 minutes break. 5 minutes break after 5 minutes at 11:35. Thank you so much.
Good morning, Rajesh sir.
Good morning.
Madam?
Madam, yeah, yes, please.
Rajesh sir is here.
Yes, sir. Very good morning, Rajesh ji.
Yes. Morning, madam.
Good morning, sir. Technical team, kindly check with the PPT presentation.
Yes, ma'am. Sir, can we once just check with the presentation? Like, can you share from your end, sir?
Yes. So can I start?
Sir, like we have just finished the first session, sir.
Okay.
Of 5 minutes, we'll be starting, sir.
Fine.
Can we have your presentation in a full screen mode, sir?
Yes.
Yes,
Thank
sir.
you, sir. Sir, just 3 to 4 minutes, please.
Sure.
Technical team, you can go ahead with the general instructions. Meanwhile,
Yes, ma'am. Dear participants, we request you all to kindly note the general instructions. Today, after this session, we have the valedictory session at 3 p.m. Dear participants, kindly note, we have a valedictory session at 3 p.m. So we request all the delegates to join the valedictory session, and our Honorable Vice Chancellor, sir, would be addressing the gathering. During the valedictory session, the link for the questionnaire, the test, would be shared in the chat box, and the test will be stipulated only for a half an hour time, and the participants are requested to complete the test within 30 minutes of time. So I request all the participants to access the link in the valedictory session itself. Kindly note, the test is very mandatory for the generation of your certificate. 80% of minimum attendance along with the minimum score of 60% marks in the test conducted are the mandatory criteria for the generation of certificate. So I request all the participants kindly do not miss your test in the afternoon session at 3 p.m. The test link will be posted during the valedictory session. Thank you. Over to you, ma'am. Dear participants, we cordially invite you all to attend the valedictory session of this 5-day faculty development program. Today at 3 p.m., you can join the valedictory session through the same Google Meet link by which we are having all these 4-day sessions. And kindly note, the examination or the test link for this 5-day faculty development program will be provided to all our participants to complete their test within a 30-minute time, and the link will be provided during the valedictory session. So I request all the participants kindly do not miss the valedictory session. Thank you.
With your permission, Rajesh ji,
Yes.
shall we move ahead, sir?
Yes, yes.
Thank you. Technical team, is everything ready?
Yes, ma'am.
So I'm Dr. Rajesh Tripathi, completed my PhD in the area of machine learning for biomedical engineering. So currently I'm working as assistant professor at Visakhapatnam, Hyderabad campus. So I normally do research on Internet of Things and machine learning for biomedical data analysis. So the theme of this presentation is like how can we use artificial intelligence for assessing the clinical data and produce the decision. So that means the diagnosing various diseases from the clinical data itself. Now,
Sir, sorry for interrupting you. First of all, I would like to introduce you and then we'll hand over the session to you, please. Thanks a lot, sir.
okay.
So, good morning, dear delegates. Welcome back to the second session of 5th day, 5-day online FDP sanctioned by AICTE ATAL Academy, India's Internet of Things Revolutionary Impact on Pharmaceutical Education and Industry from 21st to 25th September 2021. The first session ends with a talk by Mr. B. Sairamji on digital health and smart healthcare, a boon or bane. Now we have a lecture by Mr. Rajesh Kumar Tripathi ji on artificial intelligence aids pharma companies for clinical trials and assessing clinical data. Rajesh ji has received his PhD from Indian Institute of Technology, Guwahati in 2017. Sir, has masters from biomedical engineering in 2013 from NIT, India. Bachelor's of electronics and telecommunication engineering in Visakhapatnam University, Odisha. Sir worked as an assistant professor at Faculty of Engineering and Technology, Shiksha Anusandhan, deemed to be university from March 2017 to June 2018. From July 2018, Sir is working as an assistant professor in the Department of Electrical and Electronics Engineering, BITS Pilani, Hyderabad campus. Research interest constitutes machine learning, deep learning, biomedical signal processing, sensor data processing, medical image processing, and IoT for healthcare. Sir published more than 75 research papers in reputed international journals and conferences. To his credit, Rajesh ji served as a reviewer for more than 15 scientific journals and served as a technical program committee member in various national and international conferences. Sir is an associate editor for IET Electronics Letters and academic editor for Biomed Research International Journal, Hindwai. Also, Sir is working as the guest editor for Frontiers in Physiology Journal. I request all the participants to get involved and be interactive and get your queries clarified with such a legendary experience. Distinguished. Dear delegates, we get rare opportunity to interact with such a young and dynamic professional. So I request all of you to kindly let's enjoy the session by our dear Dr. Rajesh Kumar Tripathi ji. Thank you so much, sir. Over to you.
Thank you, madam, for the introduction. So mainly, I will first discuss what is IoT and how this machine learning and deep learning plays one important role for IoT-based design of smart healthcare systems, or we can say Internet of Medical Thing driven decision support system. So as we can see, we have a huge amount of data, so that is coming from the patient. So when we can also record now the ECG signals from the mobile device, we can also evaluate heart rate, and we can also evaluate oxygen saturation. So many pulse rate, many things can be recorded from the patient in a digital way. We can transmit these clinical parameters to the hospital. Now, so the IoT is nothing but we have the sensors, so which can record the data. So that means, suppose we want to record the ECG signal. So from the patient itself, we can record ECG, we can measure heart rate. Also, we can measure the EEG to know the cognitive status of the brain. And also we can record PPG data. So various data we can work from the different sensors. We can record the data. So once we have the data, we can transmit to the cloud server. So cloud server is a very important part in Internet of Things. So in the cloud server itself, we can train the model. So model means it's like one decision support system, or we can say machine learning based hypothesis we need to create such that we can deploy this in cloud server. So once we generate the data, so once we obtain the data from the patient, so you can see here patient 1, something is not right. So that means that thing is deciphered in the ECG signal itself. So once we have this ECG signal, so now we have the cloud server which can predict that suppose the ECG signal belongs to myocardial infarction. That means the subject is suffering from the myocardial ischemia or myocardial infarction. Then obviously the cardiologist will provide the treatment procedure based on this decision. So because we have the huge amount of data, so there is a huge load on the cardiologist, or you can say medical practitioner, so that they can provide the decision. So Internet of Things based smart healthcare system plays one important role for providing the decision support system to the medical practitioners. Now, so in the heart of Internet of Things, like first part is the peripheral part, that is the sensors. So by the help of sensors, we can record the data. Now the next peripheral is the interface. So that is the communication link. So that means the data transfer, data security. So all those factors plays one important role. Like first sensor, data security, then third part is like your cloud server. So in the cloud server itself, we need to provide the mathematical model, or you can say we need to deploy our machine learning or deep learning model. So mainly, so how I will give two basic introduction to that we had already published recently to our two of our work, recently developed work. So the first one is multi-scale deep neural network for the detection of shockable ventricular arrhythmia using electrocardiogram signals. Now, from the electrocardiogram signal itself, we can automatically detect shockable ventricular arrhythmia. So shockable ventricular arrhythmia is like ventricular tachycardia and ventricular fibrillation. So I will give one brief introduction. What is VF and VT? How can we detect all those things? Now the second part of this presentation is like multi-scale domain machine learning approach for the classification of sleep stages. So the classification of sleep stages is a very important phase for the diagnosis of various sleep-related disorders like insomnia, like bruxism, or sleep apnea. So for polysomnography test, when the subject undergoes polysomnography test, the sleep stage, automated sleep stage classification is extremely important. So that means whether the subject is in light sleep, deep sleep, REM sleep, or in wake stage. So those things are required for the diagnosis of sleep-related disorders. So let us start the first one. So the ventricular tachycardia and ventricular fibrillation. So as we can see here in the right side of the figure, so normal ECG means, so ECG contains the P wave, QRS complex, and PU. So ECG mainly decipher the electrical activity of the heart. So normally the doctors use the various clinical features of the ECG like your P wave amplitude, P wave duration, heart rate. So many parameters they consider for the diagnosis of various heart diseases. Now, so the ventricular tachycardia and ventricular fibrillation are shockable cardiac arrhythmias, or that means we can say, so for automated external defibrillator and implantable cardioverter defibrillator. So for initiating the defibrillation therapy, so one need to detect these two episodes like ventricular tachycardia and ventricular fibrillation. Now, so what is ventricular tachycardia? Now, ventricular tachycardia is an abnormal electrical activity, so that is generated in the ventricle of the heart. So that means, so in that condition, the heart is unable to pump the sufficient blood to lungs and entire body. So that means you can see here the normal heart as the beats like P, QRS, T, all those things. Now, so during ventricular tachycardia, we have the abnormal electrical activity. So that can be seen in figure A. So that means no longer the P wave, QRS complex, all those things only. So very high ventricular rate. So all these abnormal episodes appear in the ECG data. Now, so ventricular fibrillation is a progressive stage of ventricular tachycardia. So it is highly disorganized electrical activity. So that is again generated in the ventricle of the heart. So due to this ventricular fibrillation, the heart completely fails to pump the blood. So the sudden cardiac arrest will appear. So that means first thing is how to detect these two things. So like ventricular tachycardia and ventricular fibrillation. Now, so what we proposed one smart healthcare system to detect shockable ventricular arrhythmia and classify, so whether it is ventricular tachycardia, ventricular fibrillation, or also normal sinus rhythm. So those things also we have considered. So our main thing is now consider the ECG signal, so ECG data. Now we have applied some pre-processing tasks over the ECG data. So that means we have selected we have applied the filter to select the frequency components of the ECG data. So once we select this frequency component of the ECG data, then also the ECG duration, if we consider suppose 10 minutes of ECG data, so that means we have huge amount of data. So if you consider the sampling frequency as 500 hertz, suppose if you consider 10 minutes, so 10 multiplied by 60 multiplied by 500, so we have huge volume of data. So to develop the model, machine learning or artificial intelligence model over this huge volume of data is a very challenging thing in artificial intelligence community. So what we consider now, we segment this ECG recording into various frames. So frames means we have considered 2-second duration frames, 5-second duration frames, 6-second duration frames, 10-second duration frames. Now, based on the performance of our deep learning model, we have selected the optimal duration frame. Now, so in the first step, pre-processing, the filtering and segmentation of ECG recording into frames, or you can see ECG signal into frames. Now, next part is we have applied one decomposition approach. So decomposition approach means, so instead of selecting the entire frequency component of the ECG signal, so what we did, now we segregate the ECG segment, so based on the frequency range. So like 1 to 2 hertz, we have considered one filter. Now 2 to 6 hertz, again another filter. Now 6 to 12, again another third filter, 4th, 5th, 6th. Now, so during this ventricular tachycardia and ventricular fibrillation, so Professor Clifford at MIT has already verified that there is a shift in the frequency component of ECG signal. So ECG signal frequency component has been shifted from high frequency region to low frequency. So that means if we analyze the low frequency component of the ECG signal, then that will be helpful for the diagnosis of ventricular tachycardia and ventricular fibrillation. So motivated from this, so we have considered the fixed boundary based empirical wavelet transform to decompose the ECG signal into various modes. So let us see the modes of this ECG signal. Now, so before going for the modes of the ECG signal, so these two are the filters, like one is low pass filter, another one is band pass filter. So that means so we have constructed this filter, low pass, band pass, all those things by the help of these two equations. So first one is empirical scaling function, then second one is empirical wavelet function. So empirical scaling function will capture the information about first filter, because that is scaling part, or you can say low pass filter part. Now here empirical wavelet function, it's a band pass filter part, so it will capture the information of rest of all filters. Now, so as we can see here, now for this figure, normal sinus rhythm, so from K to O, so figure K to O, so this is the that the components extracted from the ECG signal. So as we can see here in the ECG signal, figure C, so this is the main ECG signal. If we segregate this ECG signal frequency components, so we will obtain the first 5 components as, so this one as the first component, second component, third component, fourth component, and fifth component. So as we can see, the first component captures the low frequency component of ECG signal. So as you can see here, the T wave information is here, then again T wave information. So low frequency part of T wave information is here at this subband signal, or you can say this mode. Now the second, it captures the mid-band frequency information, and the last 2 signals capture the high frequency information of the ECG. So if we do the local analysis, then only we can effectively capture the changes in the ECG data when there is a ventricular tachycardia and ventricular fibrillation. So this is for the normal sinus rhythm. So left side you can see figure A to E. So that is for the ventricular tachycardia class. So as we can see here in ventricular tachycardia, so it looks like it's a periodic pattern in the low frequency component of the ECG signal. Now this pattern, so when the ventricular fibrillation is there, so this pattern amplitude reduces. So that means so the heart rate obviously increases and the pattern start gradually decreasing. So here from this information, what we observe that if we consider this subband signal and develop our deep neural network model, so we can effectively diagnose this ventricular tachycardia and ventricular fibrillation. So this deep neural network we have developed. So that means the 5-channel input from the ECG data is used as the input for the multi-scale deep CNN. So we have considered the convolution layer. So in the deep CNN, so in the convolutional neural network, we have convolution layer, pooling layer, then we have convolution, pooling, convolution, then we have multi-layer perceptron layers. So we have developed this architecture. So first convolution layer, 20 filters we have considered. Now the pooling layer, again 20 filters. So second convolution layer, 60 filters. Then pooling layer also same number of filters. Third convolution layer, 120 filters. Then fourth convolution layer, again 120 filters. So once we have this fourth convolution layer feature maps of the ECG data at 5 scales, so then we can flatten all those things to create the fully connected layer. So once we have the fully connected layer, we can reduce the number of neurons in the fully connected layer. So to 1500 units, then 375 units, 50 units, then we have the output. So output, so it's mainly based on either shockable ventricular arrhythmia or non-shockable ventricular arrhythmia. So what we have considered now, we have tested our algorithm using the ECG data from 2 publicly available databases. So first one is Creighton University database, CUDB, and MIT BIH Malignant Ventricular Arrhythmia database, VFDB. So both these databases are publicly available. One can download and evaluate the algorithm, developed algorithm. Now, so CUDB database consists of 35 single channel ECG recording. So each recording duration is 8 minutes. Now the lead one, so obviously during the recording of ECG signal we can use 12 lead ECG system, but for the diagnosis of shockable ventricular arrhythmia, the single lead, normally the single lead ECG recording system is used. Now, so in this database, so various rhythms are there. So first one is normal sinus rhythm, then ventricular tachycardia, ventricular flutter, and ventricular fibrillation. So once we have this database ECG signal, so what we consider now, we segment the ECG data into various frames, or you can say windows. So first VT, ventricular tachycardia, we have considered 2-second episodes, or you can say 2-second frames. 1620 number of frames we have evaluated. Now the 4-second 810 frames we have evaluated. So 810 ECG segments we have considered. Now, so similarly for normal class, 19532 ECG frames, 2-second ECG frames also we have evaluated. Now, so another database also we have considered. The second one is ventricular fibrillation database, so which consists of 22 2-channel ECG recordings. So that means the first database contains only the single channel ECG recording. So here the second database has 22 2-channel ECG recordings. So both channel 1 and channel 2, or lead 1 and lead 2. So the duration of each ECG recording is 30 minutes in the VFDB database. So in a similar way, we have evaluated the number of segments from the ECG data itself. So once we obtain these segments, so we have trained our model. So this model has been developed in the Python framework with Google Colab cloud part. So that means, so as we can see from here, so there is a class imbalance problem. So normal class, we have huge number of instances, ECG instances, but for other classes we have very less number of ECG. So we have considered the class imbalance. So if we can, during the training procedure, if we can oversample the instances from ventricular tachycardia, flutter, and fibrillation, then also we can overcome this class imbalance problem. So what we consider here, now we consider the random oversampling for the minority class to overcome the class imbalance problem. Now, so we have adopted 3 classification strategies. So first one is shockable versus non-shockable. Similarly, second one is ventricular fibrillation versus non-ventricular fibrillation. Then third one is ventricular tachycardia versus so that means ventricular tachycardia versus ventricular fibrillation. Because for the initiation of shock therapy, so we need to also segregate the, or we can say we need to detect the onset point of ventricular fibrillation. So that means we also need to discriminate ventricular tachycardia and ventricular fibrillation. So these are the parameters that we have considered, training parameters in the Python framework. So 8 into 10 to the power minus 4 for ventricular tachycardia versus ventricular fibrillation as learning rate. Then the adaptive stochastic gradient descent ADAM optimizer has been used as the optimizing criteria. Then number of iterations 70. Then batch size as 18. So similarly for ventricular fibrillation versus non-ventricular fibrillation, so we have the training, or you can say learning rate 10 to the power minus 3, number of epochs as 100, and batch size as 100. So in a similar way, so we have also evaluated the classification performance using the 10-fold cross validation as well as the subject specific cross validation. So as we can see the result part, so first case is shockable versus non-shockable ventricular arrhythmia. So using 2-second ECG frame, or you can say the modes of 2-second ECG frame, we obtain the classification accuracy as 97.856%. Now, so using 8 seconds, so we have accuracy as 98.773%. So using 5-second ECG episodes, so we have now the highest accuracy as 98.87%. So for the shockable versus non-shockable, so under shockable class, so we have ventricular tachycardia and ventricular fibrillation. So for non-shockable class, we have other rhythms, other heart rhythms. Now, once we detect shockable versus non-shockable, so that the shock therapy will be initiated in automated external defibrillator or implantable cardioverter defibrillator. Now, so second classification scheme, so other parameters also we have evaluated: sensitivity, specificity, and F1 score. So as we can see here, at the 5-second instance, the F1 score is 99, highest F1 score 99.210. So similarly for VF versus non-VF, so ventricular fibrillation versus non-ventricular fibrillation, so we obtain the accuracy for the 2-second as 96.641, and for 5-second 97.649. So also we have reported the standard deviation. So for developing any machine learning or deep learning algorithm, you need to run the program multiple times. So once you run because you are randomly initializing the weight value during the first stage of the training, and finally you need to update everything. So if you run the program different times, your result may affect. So that is why it's better to run the program 5 times at least and report the mean value as well as the standard deviation value. So then the third part is the classification of ventricular tachycardia and ventricular fibrillation. So ventricular tachycardia and ventricular fibrillation episodes are highly correlated. So you cannot get 99% accuracy. So any algorithm, suppose if you develop any smart Internet of Things driven machine learning or deep learning algorithm, so you cannot classify the onset point very accurately. So that is why we have, so our model, so multi-scale deep CNN model has obtained 81.74% using 4-second ECG segments, and with sensitivity 88.27% and specificity as 75.680% with F1 score as 82.29%. So we obtain the 4-second data, VT versus VA, 4-second ECG data. So the accuracy is maximum at 81.743%. Now, so we have also selected the 10-fold cross validation based instance selection. So for shockable versus non-shockable, we obtain the maximum accuracy at 8 seconds, because 8-second ECG frame is able to capture the information, or we can say pathological changes like during normal. So that means during ventricular tachycardia and ventricular fibrillation. So that is why we got the maximum accuracy at the 8 second for shockable and non-shockable ventricular arrhythmia classification. So 99.036% for 8-second episode. So in a similar way, so we have the F1 score 99.378%. So similarly, ventricular fibrillation versus non-ventricular fibrillation. So with 4-second ECG frame, we have the classification performance as 99.680. So similarly, if we consider 8-second, also our method has obtained 99.80% accuracy. So similarly, the third case, to predict whether it's a ventricular tachycardia or ventricular fibrillation, and accordingly we'll have to adjust the shock therapy. So VT versus VF. So the classification accuracy that we obtained for the 5-second ECG segment as 83.212. So these two tables that we have discussed here. So first one is holdout cross validation and 10-fold cross validation. So best instance selection. So this is not only the intra-patient based instance selection for evaluating the classification performance of deep learning. Now, so we have the subject specific cross validation. So that means in clinical standard, normally the model should be trained with different subjects and it should be tested with one particular subject. So we have also evaluated the performance of multi-scale deep CNN model with leave one out cross validation. So leave one out cross validation based ECG data selection. So first one is ECG segment, 2-second ECG segment. The subject specific cross validation result as 94.26%. Now similarly, so at 8 seconds we got the maximum again performance 97.59% with sensitivity 99.55 and 93.14% as the specificity. So from here we can observe that, so in subject specific cross validation also the 8-second ECG frame able to capture these physiological changes in the ECG. So when we have the ventricular tachycardia and ventricular fibrillation. So normally, so when we develop any kind of automated system for detection of these two episodes, so we must have to consider the duration of the ECG frame as 8 seconds. Now, so we have compared with existing algorithms for the detection of shockable ventricular arrhythmia. So as we can see, recently directly the CNN has been applied to the ECG signal, and they have reported the classification performance as 93.18%. So that means they don't consider the local component of the ECG signal for the detection of shockable ventricular. Also, so their architecture contains 11 layers. So 11 layer means various convolution, pooling, and all those things. But our method, so in which we have considered the local components of the ECG data. So that means various frequency component of the ECG data, and use the deep CNN model for the classification. So that means the model is termed as a multi-scale domain deep learning model. So that means first is we have the ECG segregated into different scales. Now we have considered the deep CNN over that scale to evaluate the final classification performance. So as we can see, so over 11 layer CNN, so our method has obtained the better classification accuracy, almost 4% classification accuracy improvement, and it's ready to test using and it can be deployed in the Internet of Things based, Internet of Medical Things based framework for the automated detection of shockable ventricular arrhythmia. Now, so what we observe here, now we can deploy our model to here. Now, in this Internet of Things based framework, so where we need to deploy the model, so in the cloud server itself, we need to deploy the deep learning model, multi-scale deep learning model. So once we record the patient data, ECG data we record, so from the mobile device or you can say from the sensor, so we can directly transmit that ECG data to cloud. Now, so the cloud will, so that means the model in the cloud, model deployed in the cloud will provide the decision that whether this is shockable ventricular arrhythmia and non-shockable ventricular. So when so shockable ventricular arrhythmia is detected, so that means it will alarm to the medical staff, so that the staff, so the cardiologist or you can say the medical practitioners will provide one alert that initiates shock therapy immediately. So like that, so that can be accomplished by the help of this Internet of Medical Things based smart healthcare system. So it is a very recent application in the medical science. Now, so the next framework that we have considered as multi-scale domain machine learning approach for the classification of sleep stages using electroencephalogram signal. So as we know, the sleep is a very important phase for every human being, and it is very important. It plays one very important role in maintaining both mental and physical health. So 7 to 8 hours sleep is very necessary for every human being. Now, so if we have inadequate or a lack of proper sleep, so the obviously various neurological as well as various cardiovascular diseases will come. So like the various diseases like pneumonia, then bruxism, the other related diseases like neurological disease, cardiac disease, hypertension, and diabetes. So lack of sleep causes these pathologies. Now, so once we can categorize various sleep stages. Then only we can diagnose this kind of diseases like your insomnia, then bruxism, sleep apnea. So all those diseases can be diagnosed through the polysomnography test. So polysomnography is normally preferred in the clinical study to diagnose various sleep-related disorders. So in polysomnography test, so various physiological signals are recorded, or you can say various physiological data. So first one is electroencephalogram, so which reveal the electrical activity of brain. Similarly, electrocardiogram, so that is electrical activity of heart. Then we have the respiratory signal that is also used to measure the how many times your respiration, or you can say, stops during the sleep. So that means whether we have apnea, hypoapnea. So apnea, hypoapnea index we need to compute for the diagnosis of sleep apnea. So mild apnea, so 1 to 5 AHI is a normal thing. So 5 to 15 mild apnea, anything up over 15 is like severe apnea. So once the severe apnea part is detected, so that means the CPAP therapy, normally the pulmonologist prefer the CPAP therapy, continuous positive air pressure therapy will be given to the subject. So these signals like electromyogram, which measures the movement, information of movement during sleep, and also the oxygen saturation. So these things are recorded in the polysomnography test. Now also in polysomnography test, our main objective is classification of sleep stages. So what are the sleep stages are there? So one is light sleep. So first stage is wake, then we have the light sleep. So light sleep, under light sleep, so we have again two soft stages, S1 sleep and S2 sleep. Similarly, in the deep sleep, again we have two soft stages, S3 sleep and S4 sleep. Now finally we have the REM sleep. So total, so we have 6 phases of sleep. One is wake, S1, S2, S3, S4, then REM sleep. So that means, so if we consider only one modality, so that means only EEG sensor data, if we will consider, can we discriminate the sleep stages? So that means in polysomnography test, various types of modalities we consider to record the physiological signals. Now, can we detect, the objective is, can we discriminate the sleep stages from one modality data, so which will be very helpful to reduce the number of sensors in the PCG test. So that means recently, so people are developing the bioradars. So in bioradars, so without connecting any sensors, so we can also detect the sleep apnea. So that means from the radar recorded heart sound, from the radar recorded ECG, radar recorded respiration, so we can evaluate the apnea, hypoapnea index. Now, so what we consider now, we consider the multi-channel ECG recording. So once we have this multi-channel ECG recording, EEG recording, so then we segment the EEG recording into frames, multi-channel EEG frames. So suppose we have 24-hour EEG recording. So that means suppose polysomnography test has been conducted. So 8-hour polysomnography data we have now. So 8-hour polysomnography data means, suppose the sampling frequency is 512 hertz. Now, so for 30 seconds we can generate 15360. So you can see how much volume of data we have. So obviously the 8-hour will generate the trillion samples. So to process this trillion samples, it's really difficult to develop the algorithm. So what we consider now, we divide the multi-channel EEG recording into frames. So the frame size is 4. So that means 4 channels we have considered. So 30-second frames we have considered. So how many samples we have? So 4 multiplied by 15360. So that means each channel contains 15360 samples. So as we have 4 channels, F4C for frontal central electrode, central parietal electrode, so parietal occipital electrode, so then C4A1. So that means, so once we have this frame size, what we consider now, we extract the components from this multi-channel EEG data. So that means that is the multi-scale analysis. So in the multi-scale analysis part, we have extracted various components. So that means you can see for channel F4C4. So we have the modes, or we can say components for F4C4. Now, so for channel C4P4, again we have the modes. So similarly for P4O2, so channel P4O2, these are the modes for channel P4O2. So in a similar way, fourth channel also we can evaluate modes. Now, so after evaluating these modes, so what we consider now, we applied the dispersion entropy and the bubble entropy. So entropy, because the EEG is a very non-stationary or time varying data. So to evaluate to consider the non-stationarity and evaluate the complexity of the data, we consider the entropy measure. So entropy normally measures the randomness of any system, or that means, so here we consider the two entropy related features. So one is dispersion entropy, second one is bubble entropy, to evaluate these two features from each mode. So once we have these features, so we have the 40-dimensional feature vector. So by considering this 40-dimensional feature vector, we have developed one machine learning model, hybrid learning based classification method, to categorize into the classes like wake, light sleep, deep sleep, and REM sleep. So let us see how can we decompose the EEG data into various components. So this is the EEG data for first channel. Then for second channel, we have again the EEG data, third channel, then fourth channel. So what we do now, we evaluate one projected data, EEG data, from by combining these four EEG signals. So that means we have initially 4-channel EEG data. So we have obtained the projected EEG data from the equation like 1 divided by square root of m. M is nothing but 4. So we have 4 channels. So 1 divided by square root of 4. Channel 1 EEG then corresponds to channel 1 direction cosine. Similarly, 1 divided by 4, channel 2 signal, channel 2 direction cosine. So like that we obtain the projected signal. So once we have the projected signal, so we can obtain the frequency domain characteristics of projected signal. So here you can see this is the time domain characteristics of the projected signal. Now once we apply the transform, so we have the frequency domain signal. So in time domain we have the EEG data is not sparse, but in the frequency domain you can see between 0 to 45 Hz we have all this information. Now, so in clinical standard, the EEG information like delta wave, theta wave, alpha wave, beta wave, and gamma wave are used and these parameters you need to be evaluated for the diagnosis of various neurological diseases. Now, so what we consider now, from the projected data itself, we develop one filter bank. So we consider the frequency point for delta wave as 0 to 4 Hz, then 4 to 8 Hz, the theta wave, then 8 to 13 Hz as alpha wave, then 13 to 30 Hz as beta wave, then finally we have the gamma wave from 30 to 75 Hz. Now, so after evaluating all those things, now we have extracted the components. So as you can see here, the figure A is nothing but the wake class EEG signal. So EEG signal. Now, so we have the delta wave at the figure B, then figure C, the theta wave, the alpha wave, beta wave, then we have the gamma wave. So for light sleep class, S1 sleep class, so there is a change in the characteristics of EEG signal. So for the wake class, you can see, so we have many activities because the brain is also because there is eye movement and other things. So during the wake state, so that is why many activities are there in the EEG components. But in the S1 sleep, so as you can see, the characteristics of delta wave is also different as compared to your wake sleep delta wave. Similarly, theta wave, alpha, beta, and gamma wave. So now, so the figure M is the EEG signal for S2 sleep class. So that means first column is nothing but the wake class. Then we have S1 sleep class. Then we have again S2 sleep class. So the significant difference in the characteristics of the EEG data. So we can see from here. So like figure M, Now that can be deviate from your wake class as well as your S1 class. So similarly, so in that these physiological changes are correctly seen in the delta wave part, theta wave, alpha wave, beta and gamma wave. So by evaluating the features from this delta, theta, alpha, beta, gamma, so we can so that will be helpful for the classification of sleep stages. So what we consider now. So we have considered the multi-channel EEG signals from cyclic alternation pattern database in order to evaluate our proposed algorithm. So 25 multi-channel EEG recordings we have considered, and each recording has 512 hertz sampling frequency. Now, so out of this 25 multi-channel EEG recordings, so 6 recordings belongs to normal class, then 7 belongs to insomnia class, then 1 belongs to sleep bruxism, and also the another one is sleep related sleep disorder breathing, or you can say sleep apnea. So in this CAP sleep database, so few recordings have 9 channels, and also few recordings have 5 channels. So what we consider now, we consider 4 common channels. So these 4 are the common channels: P4O2, C4A1, F4C4, and C4P4. So these 4 are the common channels that we have considered from this database for evaluating our algorithm. Now, so next what we consider now, we segment the multi-channel EEG recording into 30-second duration frames. So that means it contains 15360 samples. Now, so total we have evaluated the frames like 2163 frames for wake class. So 1537 frames for S1 sleep, so 4955 frames from S2 sleep, and for S3 sleep 2707 frames, S4 sleep 2601 frames, and for REM sleep 2947 frames. So total we have how many frames? Now 17360. Now for each frame we have decomposed the signal into modes. Now again evaluate the feature, dispersion entropy and the bubble entropy feature. So the dimension of feature vector is 40. Now, so what we consider then? So we consider the hybrid classification model. So in hybrid classification model, so our objective is to take this 40-dimensional feature vector and predict whether it belongs to wake class, S1 sleep class, S2 sleep class, or it's S3, S4 or REM sleep class. Now, so this hybrid classification model what we had developed, so it is mainly based on 2 things. One is sparse representation, second one is nearest neighbor. So nearest neighbor means when you have one instance, so or we can say one feature vector, now it will evaluate the distance between the nearest training instances, so and evaluate the class level. So that means whether it is wake or light sleep or deep sleep or REM sleep. So that means you can see here step 1. So this is your training feature matrix. So in the training feature matrix, we consider for each class. So this training feature matrix is used as the dictionary. So dictionary for the sparse representation of the test feature vector. So once we have these coefficients, so like alpha 1, alpha 2 up to alpha e. So these are the coefficients for each class. Now, once we got this coefficient, so by the help of orthogonal matching pursuit method, we can obtain the residual. So residual for each class. So residual is one distance measure. So that is computed from your sparse representation. Now we have the second one. So we have the nearest neighbor distance. So if we combine these 2 distances, so then we can obtain the total distance. So this total distance equal to how much? Now residual, sparse residual distance plus we have the nearest neighbor distance. So based on this total distance, we consider the minimum of distance. Suppose we have one feature vector, so we obtain a total 6 distances, distance values. Now we take the minimum distance and evaluate the final class level. So once we have the class level, we have evaluated the performance. So the first one as the wake versus sleep. So which is also very important. So whether the person is in wake stage or in sleep stage. So binary classification is also required to know the or to predict whether he or she is suffering from the sleep related disorders. Now, the first one is hold out cross validation we have considered. So for wake versus sleep classification, so accuracy we obtained this as 88.58%. Similarly, for the 10-fold cross validation, we obtained the accuracy as 91.77%. So also the sensitivity value for 10-fold cross validation is 90.93% and specificity as 92.61%. And also the kappa score, which is used as another measure to evaluate the performance of any machine learning and deep learning model. So it's 83% or 0.83. So for sleep versus wake classification, our model has obtained only 91.77%. Now similarly, again we have the wake versus non-rapid eye versus rapid eye movement. So that means 3-class classification we have also considered. So for this 3-class classification, we obtained the accuracy as 88.14% for 10-fold cross validation, and for hold out cross validation, so we obtained the accuracy as 84.43%. So individual accuracy also we have obtained. So 83.30% for wake class. Similarly, for NREM class, non-rapid eye movement class, so the accuracy is 92.15%. So because wake and your REM, rapid eye movement, so these two classes are highly correlated. So that is why you can see here. So we got the lowest classification performance as 53.83% for REM class. So similarly for 10-fold cross validation, so we obtained the accuracy as 66.77% and the kappa score as 0.74%. So also we have evaluated the classification performance by considering the stages like wake versus light sleep versus deep sleep versus REM sleep. So for this 4-class classification task, so we have obtained the classification performance for hold out cross validation is 76.01%, and also for the 10-fold cross validation, so we have the accuracy value as 80.13%. So in a similar way, also we have considered for the wake class 84.37%. Now you can see here 72.87%. Now deep sleep 80.90%. So deep sleep is a very important phase. So when a person more and more in deep sleep, so obviously it is very good for his or her health. So that means deep sleep percentage is 80.90 as the predicted part. So accuracy for the REM sleep, rapid eye movement, so 55.58%. So obviously the kappa score is highest at 0.72 for 10-fold cross validation. So also we have considered again 5-class classification: wake versus S1 sleep versus S2 sleep versus S3 sleep versus REM sleep. So based on this hold out cross validation result, so we have 73.59% as the overall accuracy. So that means let us consider S1 sleep. S1 sleep percentage is 42.99 and wake class 85.73%. So similarly S2 sleep, which is also the important part, so which fall under light sleep. So that means the progressive stage. So S1 sleep, then S2 sleep, then finally we have S3. Then suppose in between that rapid eye movement will come. So obviously we have the 60% accuracy for the rapid eye movement. Now with 10-fold cross validation, so we obtain the accuracy as 87% here at wake class. So S1 sleep 48%, S2 sleep 74.81%, then 74.28% for S3 sleep class. Now the next type of classification, so we have wake versus S1 sleep versus S2 sleep versus S3 sleep versus S4 sleep versus REM sleep. So when if you go for the polysonography test, so after getting the report of polysonography test, you have the how much percentage there in the each stages of sleep that will decipher actually. So you can see here for the 6-class classification scheme, we obtained the hold out cross validation accuracy 71.08% for overall classification. So wake class 85.05%, S1 sleep class 45.79%. So obviously S2 slip class 75.24%, then S3 slip 58.30%, then S4 slip we have 59.71, and REM slip 72.51. So also for 10-fold cross validation, we obtain the maximum accuracy for weight class as 86.64 and S4 slip class as 82.42%. Now, our algorithm successfully classified the 6 classes, 6 slip stage classes with the accuracy as 71.68%. Also, so we have compared, so that means we have obtained the optimal parameter of our machine learning model, multi-scale machine learning model. So one parameter as sparsity level, another parameter as number of nearest neighbor. So based on this accuracy of training and validation set, we obtain the parameter, optimal parameter. So at 20 as the sparsity level and 10 as the number of nearest neighbor, so we obtain the validation set accuracy as 72.18% and test set accuracy as 72.72%. So that means these two parameters are optimal. So for the development of our model, so that means sparsity parameter and nearest neighbor parameter. So we have also compared with existing methods. So as you can see here, this method, so the time domain and spectral domain features extracted from the multi-channel EEG with dendrogram SVM has obtained 74.80% as the accuracy, which is better than our approach. So because the problem in dendrogram based SVM is a very highly computational complexity based machine learning model. So our model is nothing but a very simple model which is mainly based on the distance measure. So we evaluate the distance from the training instances to obtain the classification or you can say class level for the required test feature vector or test data. So our model has obtained 73.88% as the overall accuracy for 5-stage classification. Now, so we can deploy this model to here in the cloud server. So suppose from the patient itself, we record the EEG data. So suppose 5 hours EEG recording has been done. So with 4 sensor data. Now, once we record all those things, so here we can provide the cloud server so that the medical practitioner can have the information related to how many wake stages and how many S1 slip stage, how many S2 slip stage, S3, S4, and REM slip stage, so that, and also we can evaluate the apnea hypoapnea index from the respiratory. If we consider the respiratory signal, so how many times the blockage is there, we can also evaluate the apnea hypoapnea index, and that information can be shared with the medical practitioner. So accordingly, so the medical practitioner will provide the diagnosis support. So this will obviously these two models, multi-scale machine learning model and multi-scale deep learning model, can be. So we have also implemented the multi-scale deep learning model in real time. So that means so we have taken the ECG signal that we have collected from our volunteers and we have tested the algorithm. Now, so our algorithm successfully predicted the normal class. So that means we have not tested over the pathological thing. So we are collaborating with hospitals so that we can get the pathological signal, or you can say ventricular tachycardia and ventricular fibrillation based signals, so that we can finally test our model so that it can be deployed in the cloud server for Internet of Medical Things based design of smart healthcare systems. So these are the references for the presentations. So mainly these two works has been published in, one in Computers in Medicine and Biology journal, and second one is published in Entropy journal, MDPI journal. So Computers in Biology Medicine is a very high impact journal. So if anyone has any question, can ask.
Sir, am I audible?
Yes.
When pixel data is being taken for the convolution purpose for EEG and ECG,
Yes.
so if instrument has got a baseline aberrations and stray dots, so how will you take care of them, because it is going to influence our actual decisions?
Exactly. Yeah, exactly. So the problem in normal CN, if you directly consider the data and apply the deep learning model, so obviously your performance will reduce. So that is why one researcher has obtained 93%, because they have considered directly the ECG data. Now, if you consider the different frequency components of the ECG data, now suppose normally the baseline wandering artifact, or you can say baseline wandering noise, normally happens between 0 to 0.5 hertz frequency component. So what our model, multiscale deep CNN, so we have considered 1 to 2 hertz as one subband. So that means we have filtered out the baseline wandering part, and also the power line interference noise is very important, because power line, if we have the power line interference noise in the ECG data, obviously it will degrade the detection performance. So that is why what we consider now 1 to 2 hertz as one band, then 2 to 4, 4 to 6, then 6 to 10. So like that we have selected the few bands from the ECG data. So that is why, so as we are considering different scale information, so obviously the noise part has been filtered out. But if we consider directly the ECG signal, obviously the result will be degraded. So that is why the multi-scale deep learning approach has better performance as compared to the normal simple deep learning based ECG data analysis.
Sir, I have got another query.
Yes, please.
So you have given a rapid eyeball movement sleep and vacant state. So is there any in the literature data about state of dream and state of deep sleep, the comparison of EEG?
Yes. So various applications are there, mainly for the classification of various sleep stages during norm. See, we have different kind of diseases. One is suppose normal class, another one is insomnia. So for insomnia, the number of sleep patterns like wake, then S1 sleep, S2 sleep, S3, S4, and REM sleep patterns will be different. So insomnia patient will have more REM stays, wake stays, and S1 stays. But for the normal person, which has more S3 and S4 and S2 stays, so from that, so we can predict the hypnogram. So hypnogram is a quantitative plot, or you can say it's a plot that can represent the number of sleep stages. So normal person hypnogram and insomnia patient hypnogram, if we can compare, so then only we can see that obviously the rapid eye movement part will be very high in insomnia part, and for normal person, so less rapid eye movement during sleep. So normal person will obviously have S2, S3, and S4. So S3 and S4 sleep, S2, S3 and S4 sleeps are very important for our daily life. If we have more S2, S3, S4, then that is good for the health. So that can be seen from the hypnogram itself.
So in hypnogram, dream state will be known in which state?
Dream state is like S3 and S4. So that is deep sleep. So in deep sleep, that part is like dream sleep, we can say S3 and S4, which is very important. So normally those who do meditation, so the meditation, the people who are doing meditation, actual meditation, so they have more S3 and S4 sleep states. So that is experimentally verified also. So when one person has more S3 and S4, he or she is always happy and feel very energetic during work.
In the psychotic patients, they shout, and in between they wake up, and something they have seen in the sleep, they say that such type of delusion will come with state of sleep.
So that is the intermediate part. So that is wake and rapid eye movement. So which is very interesting research topic. So So because these two are highly correlated, wake states and rapid eye movement states. In rapid eye movement states, the person is in sleep, but the eye movement is there. So that means it will generate the ocular artifact kind of signal in the EEG data. But in the wake states, so we don't have such rapid eye movement. So eye movement is there, but so the amplitude deviation is there in the EEG signal. But as compared to your rapid eye movement sleep, so we have huge amplitude, like amplitude is in 60 microvolt or 70 microvolt. For the normal wake class EEG signal, we have only 20 microvolt. So that, because these two things are highly correlated. So for psychiatric patients, so obviously it can be the transition between wake as well as the REM sleep.
Do we have any equipment or instruments with Wi-Fi, Bluetooth enabled or Wi-Fi enabled without making the person bedridden? For 24 hours, we want to take it easy. Then it will be, person has to be in the bed only.
Wireless body area network. So mainly nowadays one instrument is there, emotive EEG recording instrument, which is mainly based on the wearable sensors. So that means the patient will wear only the like wearable T-shirt based EEG recording, and also like ECG recording, then also cap based EEG recording. So all these sensors are now available. So wearable sensors based smart healthcare system. So definitely one example is emotive EEG data recording system. So there we have wearable sensors. So it's like one cap, one can wear one cap so that we can record the EEG signal.
So when this algorithm converts a time domain to this frequency domain, so how it will take, because we are taking different stages and picking up 30 seconds or 80 seconds. So how it will pick up the critical point of the particular state, picking up for the decision making to the next state in the neural network?
Yes. So if we consider the ECG signal or EEG signal, so ECG and EEG signal, normally the frequency components are between 0.5 to 45 hertz. Now, so 0.5 to 45 hertz, if we divide these points into various scales using empirical wavelet transform, then so once, suppose for 0.5 to 4 hertz, so we have delta band in EEG signal. So delta band is component, suppose important in your light sleep. Now alpha band is important in the deep sleep part. So we can capture the information locally. So suppose in the delta band features and alpha band features, so if we can individually do the classification, so delta band entropy features, alpha band entropy features, and we have the machine learning model, if we classify, then obviously we can have better performance as compared to the direct EEG signal features. And also the direct EEG signal features are not robust to capture this sleep related changes. So that is why one can go for the local analysis, like delta band related features, alpha band related features. So the segregation of bands from the EEG signal is a very well established thing. So delta, theta, alpha, beta, gamma. So normally the frequency response is like 0.5 to 4, 4 to 8, 8 to 13, 13 to 30, 30 to 75. So all these bands, once we evaluate, so we can see that so at which phase of sleep, suppose for psychiatric patients, so normally there is a transition between wake and REM sleep. So we can see which band is changing more. So from that information, if we get the features, then only we can easily classify using machine learning models. So that is the motivation why we consider this empirical wavelet. So to mainly capture the delta, theta, alpha, beta, gamma information.
This kappa value you have mentioned, how it is different from our regular regression coefficient, and this kappa coefficient, why we use it in this particular?
So kappa score is normally measures like it for accuracy. Accuracy measures the individual class performance. For wake class, So we can evaluate the individual accuracy. So similarly, overall accuracy also we can evaluate. So kappa score mainly measures the correlation. So accuracy is one measure, then kappa is like correlation measure. So that can be, so in regression, so correlation has one meaning, but in classification, so because the outputs are discrete, so we cannot consider the correlation part. So that is why kappa is another measure which is very similar to correlation, but that is applied in classification problem. So that can be obtained from the confusion matrix itself. So from confusion matrix, we can obtain the probability of true positive, probability of false positive. So once we obtain all those things, so we can create one formula so that kappa score equal to 1 minus probability of false positives divided by 1 plus probability of true negative, true positive. So once we have this measure, so we can evaluate the classification of performance of the so that means classification performance of any machine learning and deep learning algorithm. So that means in regression, obviously we will go for the correlation coefficient. So R2 correlation coefficient, these two are very robust measures. But for classification, suppose if we have two hypnograms, how can we compare? So that means obviously we need one measure, so which can measure the true positive, false positive, all those things. So accuracy is one measure which can measure the overall classification performance. But what about for the individual class? How many false positive? How many true positive? So all those information captures this kappa score. So it's a highly robust measure for the classification part. But for regression, obviously the correlation coefficient is a very good measure.
Thank you, sir.
Okay, thank you, thank you.
Yes, sir.
Any other question?
Delegates? Dear delegates, do you have any further clarifications with sir? Thank you. Over to you, sir.
So, madam, I have finished presentation. So,
Okay, sir. Okay, sir. Thank you. Sir, dear Dr. Rajesh ji, thank you so much for having with us for this great session. And you gave a beautiful lineup with your representation and informative talk about the artificial intelligence aids pharma companies for clinical trials and assessing clinical data. Your talk holds Internet of Things based decision support system, detection of shockable ventricular arrhythmia using multi-scale deep neural network, empirical scaling and wavelet functions, modes obtained using fixed boundary based EWT, multi-scale deep CNN architecture, ECG segments for shockable ventricular arrhythmia classification, hyperparameter selection and cross-validation, results evaluated using multi-scale deep CNN, 10-fold cross-validation results, leave one-cut cross-validation results, comparison with existing approaches. So you mentioned about multi-scale domain machine learning approach for the classification of sleep stages using EEG signals, multivariate projection based EWT filter bank, subband signal plots for wake and light sleep classes, multi-channel EEG signal database, multi-channel EEG frames for each class and entropy-based features, hybrid classification model. Thank you so much, sir. We had a great elaborative session. We really enjoyed thoroughly throughout the session. We were listening to your clear-cut picture regarding the topic. The session went well, and the delegates clarified their queries with you. Thank you so much for clarifying the doubts of our delegates. Sir, may I ask you an interesting question from our side?
Sure, madam.
Sir, how can the pharma sector and your department can interconnect? I mean, can apply for some multidisciplinary projects where we can really have this collaboration so that both of us can be benefited. I mean, pharma sector and your engineering sector.
Yes. So that is a very interesting question actually. So one problem recently we are facing that so we have all these models, we have algorithms, we can classify the data, we can predict all those things, but for the real time application, so what pharma companies need actually, so similarly like COVID diagnosis. So normally various researchers are using X-rays, then CT scans, then also the multi-channel long sound, hard sound, and also speech data. So many things people have tried, and also we have also tried many models and published so many papers. So finally, what we think that if we have some actual things like what pharma company wants, like suppose like for one thing is effect of drug. So that is a very challenging thing. So effect of drug on electrical activity of brain and heart, those things. So one drug suppose may have positive side effect or negative side effect. So those things can be revealed from the EEG data analysis or ECG data analysis. So obviously, if pharma company and academics will collaborate, so one can definitely solve this kind of thing. So because these things are very unknown to the patient, so what they are feeling, so like brain electrical activity also change. So this COVID situation, people are using remdesivir and other drugs. So that will affect also the brain electrical activity. So if we collaborate, then obviously we can quantify all those things. So this is a very small application. So obviously more things can be done.
Sir, apart from our two, I mean pharma and your sector, can we include any other, I mean, in the way of multidisciplinary research?
Yes, obviously, because nowadays the agricultural research requires also the machine learning and deep learning things like smart food monitoring system, smart agriculture monitoring system. So Internet of Things has huge applications. So in IoT systems, the data science, machine learning plays one very important role. So that is why we people are strong in developing the algorithms, but we have very limited idea in the application part. So that is why. So if all areas like agriculture part, pharmacy part, everything will be combined, then only we can share our ideas so it will benefit for all people. Because so we can develop algorithm, we can also develop systems, sensor based system, but where we need to apply. So mainly so only the collaboration helps to achieve all those things.
The delegates to kindly respond if you have any clarifications needed by sir, kindly. Jagdish garu. Yes, sir.
I got clarified with queries, madam. Let me know. You have called me, I hope.
Yeah, yes, sir. So if I mean, if you have any other further clarifications, we have still time with sir.
He clarified all my doubts very clearly. Thank you. Thank you.
Okay, sir. Okay, sir. Thank you so much. Sir, what are your core research areas where we can, because we are so interested to tie up with your institute. So what is your core area so that immediately we can pick up and write for some funding agency?
Yes. So we one of my PhD student is working on this brain computer interface applications for imagined speech. Imagined speech. So when something, suppose like imagined vowel, imagined command. So can we automatically recognize what one person is imagining? So that part, my one of my PhD student is recently started her research. So one application like imagined command like up, down, left, right, forward, forward, backward. So is he successful? So that means mainly it is for the robotics application. Those who cannot speak, which have been language related disorders. So that is why from their brain signals, from their imagined speech, we can record the brain signals. So once we have these brain signals, so we can develop the IoT based system, or you can say smart healthcare system. So that will be very helpful for this kind of language related disorder people. So one application we are currently working. So also like ECG related things that I had previously worked and also currently working, atrial fibrillation. So atrial fibrillation is a very primary heart disease. So that will in future it will develop the myocardial infarction and also heart attack. So can we detect atrial fibrillation, atrial flutter, all those things, pathologies? Because because from the single ECG data, from the smartphone ECG data, so we can easily predict the atrial fibrillation. So if we can have machine learning model, so we can predict all those things. Now, so normally in the pharma company, they are prescribing certain drugs for the diagnosis of atrial fibrillation. So what is the effect of that drug? So if we can collaborate, if we can write proposals for that, then that will be very, very interesting thing.
Thank you so much, sir. That's a great corner you are working. Yes.
Madam, just I got one doubt now, madam. Will you permit me?
Yeah, you're most welcome, sir.
Sir, actually, in autism patients, EEG disturbances, obviously, can you be able to find in which state of EEG you are getting more aberrations?
Yes,
the normal.
That is a very interesting thing actually. If we have the recorded EEG signal, so we can definitely evaluate which state of is there in the. So first we need to train the model. So we must have the sufficient amount of data for the training. So once we develop this trained model, obviously we can test over the many patients like language disorders, autism, language related disorders, and other related applications. So that is a very interesting area of the research.
Thank you, sir.
Mainly the data recording part. So obviously, if we have the instrument, so here we have only the instrument, like we can record the EEG data in the ambulatory way. Ambulatory recording, like when we walk, we stand, so we can record the EEG data. So obviously, so that will be very helpful for autism disorder diagnosis.
It means you are saying wireless EEG.
Exactly. Wireless EEG, ambulatory EEG recording. So we don't have any 128 channel, 64 channel huge volume of data. So we have only four to five channels. So during standing, walking, all those things, we can easily record the data and we can store it in within smartphone or any storage device. So this is for the quicker diagnosis. So like epileptic seizure, suppose if we can consider, so that can be diagnosed based on this 124 channel, 64 channel EEG data. So also epilepsy, because when epileptic seizure come, that we cannot predict. So during ambulatory, during standing position, during a walking position, also we can record the EEG data. And that will be very helpful in future. Obviously, the fall detection, then smart healthcare monitoring. So mainly this fall detection. So the smart sensor data. So for ambulatory EEG recording, ECG, all those things. So that will be definitely the future, because fall detection is now the very important topic in IoT based smart healthcare system.
Thank you, sir. Over to you, Jagdish.
Madam, it is endless. in sleep apnea, is there any in advance signal you can get into the mobile that the person is going to that state? Intervention from the nurses required or any medical required? What is that signal will be coming in IoT to any mobile device?
Yes. So the PPG signal, plethysmograph signal. So from the PPG signal, one can easily derive the respiration. So respiration directly one can record, but the impedance pneumography that requires the respiratory signal recording. But one can also record the respiratory part, and one can derive the respiratory signal from the ECG data itself and PPG data. So once we record the PPG data from the smartphone, because easily we can record the PPG data, because by the help of PPG sensor, we can record the PPG data from the smartphone itself. Now, once we have the algorithm to compute the respiratory pulse or respiratory signal from the PPG data, so we can have the algorithm for the detection of sleep apnea. So that is very helpful. And also, so from the PPG data itself, one can detect the hypertension, like whether it is stage 1 hypertension or stage 2 hypertension or masked hypertension, because masked hypertension is a very important thing for the medical industry, because normally the blood pressure is normal, but after some hours, so again the blood pressure is high. So masked hypertension, so is a very important thing that can be diagnosed through this wearable health monitoring and longer duration based recording of the data.
Thank you, madam. Thank you, sir.
Oh.
Sir, do you have any, competition between your department and computer science and engineering? Like what we have, a competition between MPharm degree students and the MSc chemistry students for the absorption of them in industry, where in AR&D, both of work in the same area, and the thing is, the company needs to, pay much for a pharmacy graduate, and can pay lesser than the MPharm to MSc. So there we have some competition. So do you have that kind of any competition with the computer science department or any other department when you go to the industry or enterprise?
Yes, madam. The computer science is a huge area. So that means the medical informatics, biomedical data science is the part of computer science engineering. So in biomedical data science, so obviously biomedical data science is the must thing for pharmacy people, and also for the MBBS people, MD, MBBS people, and also for the biomedical engineers and anyone who is interested to work on biomedical engineering. So that is must thing for all people. So for pharma company, so if the data science part, biomedical data science part course curriculum will be introduced, so that will be very helpful for them to get the very high package job actually. So one factor is biomedical data science. Second one is medical instrumentation. So these two things, I think medical instrumentation will be there, but biomedical data science is very important now.
So do you work in the area of 3D printing?
3D printing, so till now I had not worked. One professor here, Professor Goel, he is working rigorously on flexible electronics, 3D printing, so and also biomedical nanoscience, nanosensors, and another one of my colleagues, Dr. Parikit, he is also working in this area, like nanomaterials, 3D printing, all those things. And also we have the facility like clean room facility. So there are so many things that they are doing. But my area is only the data science, biomedical data science, and machine learning, deep learning. So if you are interested, I can definitely help to collaborate with Professor Goel. So he's a very high quality researcher.
Thank you so much, sir, for such a big cooperation, not only from you, from your assuring on behalf of your institute. So it's really a welcoming. Sir, we have a question in the chat box.
Yes. Yes. So
Sir, can
IoT-based early diagnosis of oral cancers. So yes. So that means from cancer disease can be diagnosed from the various imaging modalities. So imaging modalities like MRI image, ultrasound image, and also CT scan image. So many images are there. So once we got these images, so we can develop the various deep learning approaches. So once we have this deep learning model, we can deploy in the cloud. So for the diagnosis, whether it is benign or malignant. So when it is malignant, whether it is stage 1, stage 2, stage 3. So total we have 4 classification. So one is benign. So then stage 1 malignant, stage 2 malignancy, then stage 3. So like that, one can design the smart healthcare system. So obviously you need the imaging part. So like nowadays handheld ultrasonic devices are there. Handheld ultrasonic devices which can be tuned to produce the high quality ultrasound image. So once we have these images, obviously one can predict so the tumor belongs to whether it is benign or malignant. So mainly handheld ultrasonic device. Yes. So exactly. So hybrid model, once we have the features, one can use definitely the hybrid model. So when we have the signals, directly the signals or the images, so the feature extraction is not necessary. So one can definitely apply the CNN. So neural network. So CNN doesn't require any feature extraction stage. So features it can evaluate, but hybrid model requires the features to be extracted from the biomedical data. Yeah. So in the early stage, so drawbacks are like, suppose the malignancy stage 1. So according the treatment will be different. So if you can successfully diagnose all those things, then only accordingly the treatment will be given. So suppose one stage, the stage 3. So obviously the immediate therapy is required. So that so if you will not diagnose, so that means if you will not detect it as stage 3, so then obviously so the patient will die. So that is the main thing is, first you need to diagnose the cancer disease at the early stage. So that is why so it's better to consider the image modality. So once we obtain the image, so let us prepare the network in such a way that so it can successfully predict whether it is stage 1 or stage 2 or stage 3. So drawback mainly when you have the misclassification rate. Suppose it is in stage 1, so if it is predict benign, so that means it is false classification. So again, so by looking the tumor size, then other parameter in the image, the radiologist will predict now this is the tumor is vascularized, now it is in stage 1, so accordingly the treatment will be given. So again, that is the manual process. So that is again the drawbacks of early stage diagnosis. So when you need one robust network which can classify whether it is benign stage or malignant 1 stage. But for other stages like malignant 2nd stage, malignant 3rd stage, so the model will successfully predict the classification.
Thank you so much, sir. Do you have any kind of, application or any? Are you doing working on some research in the areas of Parkinson's disease and brain stroke?
Yes. So, madam, we have planned to work on this gait analysis for the detection of Parkinson's disease. So daily activity data, so from the sensors like accelerometer, then also the magnetometer, GPS, all those things we have already purchased. So my undergraduate students will record the data. So once they record the data, so when suppose we have different kind of surface, smooth surface, rough surface. So if one person is walking in the rough surface, so from their sensor data and also the smooth surface, so we can predict at which surface the person in. So accordingly, So we have, suppose the person has Parkinson disease. So one feedback, or you can say one feedback suddenly come to his mobile phone that this is not smooth surface, so you cannot walk there. So so that the patient have higher chance that stroke will not happen. So like that we are actually thinking to do, but so this time I will apply one proposal related to this in the DST. So hope everything goes fine. So that is why it's in planning stage. So obviously, one if we can collaborate with pharmacy industry and other things, so that can be accomplished. But I don't know what will happen in the future. But let us see what will happen.
Sure, sir. Thank you so much. Because I mean, around 15 to 20 days back, I think, if I remember right. So we had 3 to 5 cases in Vizag who were not having even the history of diabetes, hypertension, arthritis, or any other issues. The 3 persons are around 50 plus age, and 2 persons are around 70 plus age. But without any history, suddenly in a night they got a brain stroke and paralyzed one leg and hand. It was so pathetic, and it was so trouble to see all of them.
Yes, madam. Because this fall detection is a very challenging topic in future. So that means all in every pharma company, all academics, so everything so should focus on this topic for smart living and for smart city, and because our prime minister has already told that smart city project, smart living, all things are smart. So smart means first thing is fall detection, because elderly people always so the chances of fall will be very high. So if we want to develop the smart system, so our first objective should be the fall detection. So fall detection, we need the multi-sensor data. So that is why so the application like IoT, IoT for healthcare, machine learning, deep learning, data science. So these 4 things will be combined to the pharmacy education and also medical education for the development of such systems.
Thank you so much, sir. We had a great lecture, and like we discussed, I was so confused whether you belong to engineering or whether you belong to the
Madam,
pharmacy.
because everything is now interdisciplinary, so it doesn't matter what we will work. But finally, it's a very good experience for me also, because I was also confused that what thing, because whether this empirical wavelet transform, all those things can easily understand by computer science and electronics. So what I need to present. So that is why my first slide is based on the IoT based decision support system. So from today morning itself, I had prepared this new slides actually.
Thank you so much, sir. And let's have a pic with all the delegates. Sir, we request you to kindly be in video mode for 2 more minutes, and we will have a picture with all the delegates.
Sure.
May I request you to close your deck, please? Sir, we approached you for this lecture in the last minute. From wholeheartedly, from the bottom of my heart, I mean, we are so privileged to have you. Even we have not given time to you for this session. And in the last moments, what happened is we have planned for some other things, and things could not be in practical. So we thought of having another, technician or professor for our session. So we approached you through Dr. Shiva Reddy Challa. We also had the lecture from Shiva Reddy Challa on the first day, second session. So we were extremely happy, and we express our deep gratitude for that thing, sir, and hope you are comfortable with the rush.
It's all right, madam, because so Ross things happen for the best thing actually. All right.
Thank you, sir. Sir, may I request you to kindly close your PPT? I request all the participants to please come into video mode. Let's have a picture with sir. Technical team.
Yes, ma'am. We request all the participants to please be in a video mode. So here we go. The last pick of our faculty development program in our sessions. Let's all cheer up. Here we go. 3, 2, 1. Smiles. Thank you, ma'am. Over to you.
Thank you so much, and have a nice day. And we again meet at 2:45 sharp for our valedictory. Have a great day, sir. Thank you so much.
Thank you, madam.
I request the participants to kindly stay with us for 5 more minutes. I hand over the mic to the technical team. I request the technical team to kindly.
Yes, ma'am. Dear participants, we welcome you all to be a part of the valedictory session, which is to be commenced at 3 p.m. So we request all the participants to be present at the valedictory session of the 5-day faculty development program at 3 p.m. today. And we request all the participants to kindly be into the meet 15 minutes before, so that we'll have some announcement regarding the examination. That is the test which is to be given by the participants for the generation of certificate. So kindly note, dear participants, we request all of you to attend the valedictory session. We'll have our Honorable Vice Chancellor, Sir, Professor PVGD Prasad Reddy, Sir, in our valedictory, and he'll be addressing our gathering. Later on, we'll be providing the feedback link for the day 5 and the link of the test, which is to be submitted within half an hour, that is 30 minutes time, by all the delegates who have attended these 5-day sessions. So we request all the participants who have been with us with all these 5-day program, it is mandatory to have 80% attendance and a 60% of score in the test. The both parameters are considered for generation of your certificate. So kindly note, so all the participants, please note the link of feedback and the link of the test will be communicated to you through the chat box in the valedictory session, that is 3 to 5 p.m.
Dear technical team.
Yes, ma'am.
I request you to kindly play the inaugural session of the FDP.
Yes, ma'am. Ma'am, please give me 2 minutes time, ma'am. I'll just share the...
Yes, sure.
Good afternoon, ma'am.
Good afternoon.
Hello.
Madam, please.
Ma'am, madam, is this sessions available on YouTube, ma'am? Later, no, if not now, maybe after 1 week or after 10 days.
Yes,
Are they available?
Yeah, we all recorded all the sessions.
Okay.
Yes, you can reach us.
Okay, ma'am. Thank you, ma'am.
any of the delegates, if you would like to, suggest, you would like to give some feedback, or yeah, whatever you can.
Good afternoon, ma'am. This is Sukhwant Singh from Bhopal. Yeah. Ma'am, actually, the thing is that I have been thoroughly present in all the sessions, but my device was giving a lot of problem. So because of that, I had to log in simultaneously from mobile as well as from the laptop. And sometimes, when given a chance, I was not able to speak. And recently, also, I was not able to present myself in the photograph. So will that also count in attendance, or how will it will be
No,
managed?
sir, no, sir. Because entire screen will not cover the entire people who are attending.
Of course,
So it's
of
not a
course,
big
ma'am.
deal.
Yes, ma'am.
Somewhere in some or the other, you can be. So, and the afternoon valedictory, it is better you only join with your mobile, sir. That
Yeah,
I
yeah.
think that will be sufficient so that we can have a picture.
Okay, ma'am. Thank you
Because
so
in
much,
the
ma'am.
afternoon, we'll be having multiple pictures, like with the various, speakers, with administrative, administrative staff and our technical team, and only with the delegates. So we'll be having plenty of other pics. So somewhere or other, we can cover all the participants.
I'd like to have this memory, ma'am, because I have been associated with Visakhapatnam for a very long time. So
Oh.
it will be a great pleasure for me to be, in that picture.
Thank you so much. Let's meet whenever you come to Vizag. You just ring me. I think we can continue this ATAL FDP WhatsApp group for our professional
Of course,
proceedings
of course,
further.
of course, ma'am.
We
Yeah,
can collaborate, and we can, we can go from this point to any point in our future career. So
that's true, ma'am.
I request all the delegates to let's, I mean, uh, be in line with this, and it is
Of
my
course.
humble request. If anybody is having any difficulty, you can please.
Sure.
So
So
there,
nice to hear you. Thank you.
thank you, sir. Thank you.
Architecture with large, well-resourced, vibrant, multidisciplinary institutions need to be created, or existing universities, HEIs, need to be transformed, imparting high-quality teaching, learning, research, and community engagement. This can only be achieved by these things which AICTE has already done. Now, revision of curriculum with multidisciplinary approach, with engaging all partners or stakeholders of education, be it industry, be it community, employers, everyone has been roped in with a sprinkling choice of subjects, even beyond engineering, humanities, liberal sciences, social sciences, music, art, drama, legal studies, sports, everything has been incorporated. Now, experts from other fields, legal, agricultural domains have also been incorporated. I would only touch upon one more scheme which AICTE has done, and that is to ensure that our teaching community, our fraternity, our teachers who are teaching in all our colleges are motivated, energized, and absolutely capable to teach four subjects in this area. So, competent and committed faculty is the essence of any higher education or youth. So AICTE is committed and continuously working towards creation of conducive academic ambience of creativity, autonomy, attractive remuneration, and encouragement profession. All these are parts of our approval process handbook and also the proposed governance model of AICTE, which AICTE has proposed. Now that AICTE's Training and Learning Academy, we have already imparted training to 2.3 lakh faculty members on emerging niche areas. Of course, last year's members are also such as IoT, machine learning, deep learning, augmented reality, virtual reality, robotics, blockchain management. And these are through a 1 week long 1,700 faculty development programs. MOUs have been signed with various technical universities across the country towards comprehensive, continuous, and rigorous faculty development. Another one, which is faculty development bureau, that takes care of continuous training faculty members on pedagogy, examination reforms, curriculum design, Leadership and faculty development are strategic priority, and AICTE's UK, we have a collaboration with United Kingdom. This leadership is key, is effectively utilized for higher level of leadership and administrative health. I will stop myself here because remaining parts probably I'll cover in the next stage. So AICTE is committed to ensure that NEP is implemented in letter and spirit, and all our faculty members, they are fully committed, they are trained in the core competency, so that when they go to their classes, they are absolutely confident that they can transact this curriculum very well, and it is a very strong, enriching teaching learning. I request all my coordinators that they take these trainings very, very seriously. All faculty members take these very, very seriously. And quality is our aim. All the very best. Thank you so very much. Thank you. Now, may I request Rajiv Kumarji to address the August fair. Thank you.
Thank you, Madam. Thank you for highlighting some of the important points of national education policy. Respected Vice Chancellor of Guru Ghasidas Vishwavidyalaya, Professor Alok Kumar Chakravarti, my colleagues at AICTE, Madam Mamta Rani Agarwal ji, Mitatta ji, Dhar ji, and coordinators of 72 faculty development programs being organized at various parts of the country. Very good afternoon to each and everyone. First of all, I would like to say thanks to Professor Alok Kumar Chakravarti for accepting our invitation and also helping AICTE in many, many ways. Recently, he has joined as Vice Chancellor at Guru Ghasidas Vishwavidyalaya, and immediately after joining, our collaboration, cooperation in all areas has started, not only in conducting a faculty development program, and in many other areas also. And we are also planning to enhance this cooperation in many more areas also. Thank you. Thank you very much, sir, for your help and support. Now, Madam Mamta Rani Agarwal set the tone of this inauguration function by discussing various aspects of the new education policy and the conduct of this faculty development. So I will just share the background, how we started to conduct this faculty development program and what prompted us to take that action that we should start the academy known as the AICTE Training and Learning. So in 2017, AICTE adopted a quality agenda, and there were 10 points. And one of the points was to prepare the prospective plan of the technical education in the country. That was the first time any regulatory body took initiative to prepare the prospective plan of the technical education in the country. We constituted a committee under the chairmanship of Sir P. Mohan Reddy, who is the chairman of IIT Hyderabad and also a great industrialist. And there were members from all industrial bodies in that committee. Now the mandate we initially gave to that committee to prepare a long-term perspective plan of the country. And after deliberation and discussion, the first recommendation of the committee came that it is very difficult to give a long-term perspective plan of the technical education because the technologies are changing so fast. Coming out with a long-term perspective plan will not be a right thing. So the committee gave us a medium and short-term perspective plan. So the perspective plan given by the committee was the medium and short-term perspective plan of the technical. And the main recommendation, as Madam Mamta was pointing out, that we should start courses only in the thrust areas. They identified 9 thrust areas. We all know the thrust areas. These are AI, IoT, robotics, 3D printing, blockchain, AR, VR, quantum computing, all data sciences. All these were there thrust areas. And the recommendation was that AICTE should not start new courses in traditional practice. They should give approvals only in these trustees. So that was the first recommendation of the committee. Then we constituted another committee we put this recommendation towards the committee of academic experts. Now the academic experts we drawn from almost all the IITs and the eminent person in the academic arena. They discussed and deliberated on this recommendation of the committee, and they recommended the committee of academicians recommended that AICTE should not start courses, BTech courses, 4-year BTech courses in all such trust areas. So today there is the main requirement. Tomorrow there will be crisis. They will start as minor or major in these trust areas. Only they can start a full-time 4-year BTech program, AI and data science. So that was the recommendation of the second committee that was comprising of the academicians. We accepted the recommendation of that committee and immediately we stopped giving approval, new approvals in the traditional branches that we stopped. New colleges don't go once we start traditional branches. We stopped that type of practice for 3 years, and we gave only approvals in the first areas with main, minor, or major. And one more program that is featured in AI and data science. That was the background of that initiative. Now the immediate thing was that who will teach all these technologies? Because our teachers, they joined the academic institution 10 years back, 15 years back, and these technologies, they are the very recent one. So immediately we decided that we should train our faculty members, and this is how this AICTE training and learning academy, what we call as ATAL academies, that was the birth of the ATAL academy. And first year, we, as usual, we started programs conducting in the offline mode, and we could train only 1,000 teachers. Next year, 1,000 teachers. And then immediately, this pandemic gave us an opportunity. That was an opportunity for all of us. And our team at ATAL exploited that opportunity, and we immediately converted, without wasting any time. We converted to the online mode. We were apprehensive initially. What will be the outcome of that online mode? Because we were not used to all these technologies. Our teachers were not used to, but we started. And I salute to my coordinators, my teachers. They adopted this technology very well. And all these faculty development programs, they were very, very well. And they were appreciated. And there was a lot of seriousness among the teachers. They were not the programs like that, where people were faculty to visit other places. They attend 1 or 2 days, they go for a local visit, and this type of culture was not there at all. And each and every program was culminating by tests, and that was taken very, very seriously by our coordinators. So first year, that year we trained around more than 150,000 faculty members, and that achievement was recognized by World Book Record London, and we had the certificate of that. Now next time, we should also concentrate, because when we are teaching the number of faculty development program, we were ensuring that quality was not deteriorated. We constituted a committee who is taking care of the quality of this faculty development program being organized now. So they are taking feedback, they are attending the programs, and they are taking on their feedback, they are improving, they are sharing the feedback of our experts to our coordinators, and we are always trying to improve the quality of these faculty development. And this year we have trained more than 1,500 faculty development programs, with a target to train more than 250,000 faculty. So this was all the story and the things behind how we started this ATAL academy. And almost on every Monday we are inaugurating 30 to 70 to 80 faculty development programs. And previously this program, inauguration program, was a very, very long inauguration program. Then we maintained this because a lot of time was going in this inauguration, and we thought that one officer from AICTE and one chief guest from one prominent institute will be there, and this is how we are conducting this inauguration function and the faculty development program. So with all these words, I thank all the coordinators for joining this inauguration program. I also thank my AICTE team for coordinating this program in the most professional manner. This is one more thing I want to say. This is being organized. We are conducting this faculty development program with only two or three staff members, one or two officers like our Madam Mamta Agrawal and 2 or 3 or 4 officers and 3 or 4 supporting manpower. And we are not getting even a single complaint, whether it is related to the certificate or related to the fund transfer. So they are professionally we are managing each and everything. So I thank my AICTE team, headed by our advisor, Madam Mamta Agrawal, also for conducting and continuing this faculty development program in very systematic manner. With all these words, thanks to everyone for joining this conference. Namaskar.
I now request our Honorable Chief Guest, Vice Chancellor, very dynamic, distinguished Vice Chancellor, to kindly address this August gathering.
First of all, a big congratulations to AICTE Training and Learning Academy for conducting such a wonderful faculty development program. I understand there are as many as 72 simultaneous faculty development programs being conducted today. So I can anticipate this number of professionals to be grouped up by this wonderful activity. Mr. Rajiv Kumarji, Member Secretary, AICTE, I have become a great admirer of you through only one meeting. And I can see the kind of driving force once I met you, and then I became a great friend of you. And I'm sure under your able leadership, AICTE is going to do wonders in the field of technical education in coming years. I have all words of praises for you. That's really wonderful.
Professor, if you can increase your volume a little bit. So if you can just increase your volume. I think, sir, your volume is little. Thank you.
Just give me a second. I'll get you connected with this. Sorry for the inconvenience. Our teachers, our faculty members, our experts, our technocrats will deliver extraordinary knowledge to the field of technical education. I can foresee that there is going to be wonderful changes in the pedagogy, in the curriculum, and the practical exposure, multiple entry and exit, degree from multiple institutions, academic bank of trade.
Yes, Professor Alok Kumar Chakravalji, Vice Chancellor.
Thank you so much, Alok sir. Anytime you are in AICTE, please give us the privilege to meet you.
Thank you very much.
Thank you, everyone. Have a very, very pleasant day and a great learning session through ATAL Academy. Thank you.
Thank you very much.
I request the participants to join the valedictory at 2:45, please. Thank you so much. I request the technical team to close the session for today and rejoin the session at 2:45.
Yes, ma'am.
I once again request all the delegates to join the valedictory session at 2:45 p.m. today. Thank you all.